Good morning and a warm welcome. On behalf of the organizing team, happy to greet all the respected seniors, faculty, delegates, dear colleagues, exhibitors, and all the associates. I thank you all for coming on the right time and allowing us to start the CME on time. We will start with IMA prayer and lamp lighting. I would like to call Dr. J.S. Khurana sir, Dr. K.C. Sharma sir, Dr. Fuluria sir, Dr. A.S. Sohn, Dr. Anil Agarwal sir, to please come for the lamp lighting ceremony and IMA prayer. And with this, I hand over the stage to Dr. Manmeet Kaur.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
I request all the delegates to kindly stand up on their seat for the IMA prayer. सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् न तो हम कामे राज्यम न स्वर्गम न पुनर्भवम कामे दुख तप्तानाम प्राणिनाम आर्तिनाशनम. Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibility as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the committee of nation. Jai Hind, long live IMA.
A very good morning to all. I welcome you on behalf of IMA Haldwani for the CME session. Without further ado, we will begin with our first lecture, and I would like to welcome Dr. Rohit Goel on stage for the first talk. Dr. Prakash Pant sir, Dr. Arun Kapoor sir, and Dr. Bhandari sir will chair the first session. Sir, please. The topic of discussion for the first talk is Management of Anemia in Chronic Kidney Disease, a New Pathway. Dr. Rohit Goel is the consultant nephrologist, Krishna Hospital and Research Center, Haldwani.
Friends, we are happy that we are strict on time, and we welcome you all to the first lecture. Dr. Rohit will be delivering on the anemia CKD. Dr. Rohit, please, he needs no introduction. He is a consultant nephrologist at Krishna Hospital, Haldwani. Dr. Rohit, please.
Good morning. Good morning, respected seniors and my colleague. First of all, I want to say thanks IMA Haldwani to give me this opportunity to present an important and one of my favorite topic, anemia in CKD patients. Even 3 years before when we meet, I discussed the same topic, but at that time I mainly represent the current available treatment like erythropoietin and oral and injectable irons. But this time I way forward a new pathway, a new molecule already available and approved in the market, a new breakthrough in the management in the anemia and CKD patients. Just as a brief, as we all know, India is diabetic capital, and every fifth Indian adult is diabetic, every third is hypertensive. When we talk about the prevalence, it was around 16 per thousand in Chennai and 78 per thousand in Delhi. So the burden of CKD is progressively increasing. And anemia is one of the important comorbidity and complication associated with chronic kidney disease developed early in male as compared to female. And not only affected badly the quality of life of these patients, they also affect the mortality, the progression of kidney disease, number of hospitalization, relative risk of death, cognitive functions, and the detrimental effect of the brain. Just brief about the pathophysiology of anemia. It is not only the decreased nephron mass, also the poor oxygen sensing mechanism as well as the peripheral EPO resistance responsible for the decreased EPO production in these patients, ultimately leading to anemia. The two major organs responsible in this pathophysiology are liver and the kidney. Kidney definitely because of the decreased nephron mass, but as we all know, CKD is an inflammatory state, and in that state, the liver is also upregulated hepcidin production, which is a chronic inflammatory marker. Clearance of this hepcidin is decreased because of these nephron mass in CKD patients that ultimately lead to a decreased absorption of iron from the duodenum as well as decreased release from the macrophages, and this iron is mainly responsible for the production of RBCs. So not only the decreased EPO production as well as the peripheral EPO resistance and the iron availability, the multiple factors responsible for the pathophysiology of anemia in CKD patients. We all know the prevalence of anemia increases as the disease progresses. And almost more than two-thirds patient of CKD developed anemia when they entered in ESRD. That's in stage 5 of CKD. We already discussed the current treatment like injectable preparations of erythropoietin as well as oral and injectable irons. This approach definitely reduced our dependence on the blood transfusion, improved the quality of life, but had certain limitations. When we talk about the erythropoietin, basically we give erythropoietin a super physiological dose, and later on it developed the hyporesponsiveness that ultimately lead to the complications associated with erythropoietin like hypertension, various cardioembolic events, progression of diabetic nephropathy, and in some patients, they developed pure red cell aplasia and anaphylactic reactions. And the limitation regarding the injectable and oral iron preparations are basically poor GI tolerance, bacterial growth, increased CV outcomes. So there is definitely a need to newer pathway for the management of anemia and CKD. When we talk about the evaluation of the management, in the early 1950, there's only the blood transfusion the available option. Later on, injectable iron preparations are available. The first breakthrough came in 1909 when the erythropoietin get approved for the management of the patient. After that, up to 2010 or what we can say up to 2012, only the development are in the form of various preparations of erythropoietin and various injectable iron preparations. Some are short-acting, long-acting preparations. But in 2012, a new pathway was approved for research that is hypoxia-induced factor prolyl hydroxylase inhibitors molecule. And later on, a number of molecules get developed. And first molecule was approved in India in 2002 with the name of desidustat. So what are these molecules? They are basically called as HIF stabilizer or hypoxia-induced factor prolyl hydroxylase 2 inhibitors. The most important thing with these molecules are they are orally active. They inhibit the prolyl hydroxylase enzyme responsible for the degradation of hypoxia-induced factor alpha subunit and ultimately lead to endogenous erythropoietin rather than when we need to give it externally. The only concern with these molecules are they have potential pleiotropic effects. So, what is the normal oxygen sensing mechanism in the body? Whenever there is a anemia, it induces a hypoxia in the tissue. This hypoxia work as an inhibitor of prolyl hydroxylase enzyme. Because of the inhibition of this prolyl hydroxylase enzyme, more and more HIF alpha unit is available to bind to HIF beta unit, and ultimately it increases the endogenous erythropoietin induction production in the kidney. But these effects are not only limited to the kidney, they also causes decrease in hepcidin level, which is a chronic inflammatory marker, as well as ultimately lead to increased iron availability. So what these new molecules do, they basically are the competitive inhibitors of this prolyl hydroxylase enzyme. And when they bind to this prolyl hydroxylase, ultimately creates a hypoxia, artificial hypoxia like situation in the tissue. And this hypoxia induced factor alpha unit more is more available to bind with the hypoxia beta unit and ultimately lead to the endogenous production. But this effect of these molecules is not only limited to the kidney, it is a generalized effect. And the hypoxia induced factor is get upregulated in almost all body tissues. Because of this, these molecule has potential pleiotropic effects, could alter the metabolism of glucose, fat, mitochondrial activities, and ultimately lead to alter the inflammation, cellular growth, vascular tone, as well as cellular differentiation. Some of these effects are definitely beneficial, but some are concerning. There is numerous molecules already get developed and approved. In India, desidustat was approved in 2022. There is a meta-analysis comparing the effect of these molecules to the comparing available therapy like darbepoetin and placebo, and we can easily see not only improvement in anemia, these molecules are also associated with decrease in the level of ferritin and hepcidin, so definitely improve in chronic inflammatory state, as well as improving the iron metabolism in the form of increase in total iron binding capacity. Some studies also show decrease in cholesterol level, and the most important concerning factor with these molecules like upregulation of vascular endothelial growth factor was not found in this meta-analysis. The effects are almost similar when we compare the dialysis-dependent patient to non-dialysis-dependent patients, and the similar results we found, like upregulation of improvement in iron binding capacity, decrease in ferritin and hepcidin level, and in limited numbers of study also shows a decrease in cholesterol level. So, a brief about the desidustat already approved in India. It is a phase 3 study when we compare both dialysis dependent as well as non-dialysis dependent patients to currently available gold standard treatment, that is erythropoietin. It is a randomized multicenter trial where we compare desidustat versus darbepoetin with the primary endpoints was the improvement in hemoglobin, secondary endpoint was time to achieve the improvement in hemoglobin, and decrease in cholesterol level, decrease in hospital level, upregulation of vascular endothelial growth factor, and comparison in their particular side effects. And the good thing was the desidustat was non-inferior in the improvement anemia in this patient, as well as the potential side effects are quite comparable in both arms. We can see in this chart the improvement in hemoglobin level, the serum iron, decrease in ferritin level, and improvement in transferrin restriction is quite comparable in both the arms. The results are similar when we compare these two molecules in dialysis dependent patients. And we can see the side effect profile was also quite comparable, and the things was concerning was not as well we are theoretically discussed in practical ways. So, what are the dosing schedule of desidustat? In non-dialysis patient, we can start with 100 milligram thrice in a week and upregulate up to the 150 milligram thrice in a week. For dialysis-dependent patient, we again those patient who was not already on erythropoietin, we can start with 100 milligram thrice in a week. But those patients who are already on erythropoietin, we can titrate according to their erythropoietin doses. We need to check improvement in erythropoietin level every 2 weekly up to at least initial 8 weeks, and up and down regulate according to response to the therapy in the form of 25 milligram per dose. Either we can increase to 125 milligram at a time or decrease to 75 milligram, depending upon improvement and decrease in hemoglobin level according to these drugs. So, what are the potential benefits? The most important one, they are only available as compared to the current gold standard treatment, which are injectables. They increase and maintain the hemoglobin in both dialysis and non-dialysis dependent patients. Not only increasing the erythropoietin production, they also improve the chronic inflammatory state, improve the iron availability, devoid of side effect, which is associated with erythropoietins, and in some studies they also improve the cholesterol profile. Potential concern. Definitely, we see theoretically they upregulate the cellular differentiation, can cause cellular growth, and they also a potential upregulator of VHL gene. So, those patients who has a prior history of malignancy and a high risk of malignancy, we cannot start these drugs or we can avoid these drugs. Again, the similar with the cyst growth. Those patients with cystic, disease, whether it is polycystic kidney disease and cyst anywhere in the body, we can avoid these agents. The other concerning things like retinopathy, progression in retinopathy, liver dysfunction, hyperkalemia, thromboembolic events, the result was almost quite comparable, and no data is available to discontinue or not using these agents in these patients. Though there is no clear guideline till now for the use of these agents, the only recommendations the Asia Pacific Society of Nephrology says we can easily use these agents as compared to the erythropoietin, particularly comparably in those patients who are not willing to take injectable therapies, not want to frequent clinic visits for their injectable erythropoietin therapy, and those patients who are developing erythropoietin hyporesponsive in due course of time. So now I am concluding my topic. These new molecules are the novel class of drug. The most important thing, they are orally available, equally effective in dialysis dependent and non-dialysis dependent patients, and also improve the iron metabolism into the body. Though it is a class effect, and those need to be individualized depending upon their provided hydroxylase inhibition, their duration of action, response of therapy, and dose interval. Definitely, the concerns are high, and long-term data is needed to approve the therapy as well as about their side effects. Thank you. Thank you.
for enlightening us with the renal related anemia, because as a medical community we encountered different type of anemia in our general practice. We encounter pregnancy related anemia, anemia of chronic illness, anemia of worm infestation, but this anemia is totally different. Renal related anemia is totally different pathophysiology, different management, different prognosis. So thank you, Dr. Rahul, for enlightening us with different aspects of these renal related anemia, because by getting this knowledge, we can differentiate and we can manage this anemia in a more effective manner.
Thank you, Rohit. Thank you. Dr. Rohit has completed his talk well in time, and we have 2-3 minutes for questions. Audience, if you have any queries, you can ask Dr. Rohit.
Sir. Sir. Uh,
Audience on mic.
Sir, in the all available molecules, desidustat found the best one, particularly in dialysis dependent patients, and almost using from last 6 to 8 months in Indian market.
I think it was first it was roxiplastat which was introduced in India by the name of Evranzo probably.
Yes, sir.
So is it superior or the salt is
Sir, comparable study shows the best result with desidustat.
because I think that's the only thing which is approved by FDA also.
Yes.
So, friends, what I have taken from Dr. Rohit's lecture is erythropoietin is still the molecule of choice if person is willing to get injections. And HIF stabilizers, since they are new drugs and the toxicity is not well known.
Yes, sir.
So this should be kept for those who are not willing to take it or who are seriously ill, I think.
Even the
Except
recommendation same, sir.
Except many.
Yes, sir.
Thank
Even
you, Dr. Rohit.
sir.
Thank you, Rohit. Thank you.
Thank you, sir.
Thank you, sir, for a wonderful and interactive talk. I would like to call Dr. J.S. Khurana, sir, to felicitate the chairpersons and the speaker. सर को दीजिए He will be getting the memento, sir. Yes, sir. हाँ, for the speaker. हम अभी ऐसे ही करेंगे। ये अभी पहले ये करवा दें, इसके कराते हैं। A big round of applause, please. We want an active participation from the audience. Thank you. Let's welcome our next speaker, who will be speaking on the topic New Guidelines for the Global Initiative for Asthma, Dr. R.G. Nautiyal, sir, Professor Sushila Tiwari Medical College, Chest and TB, Haldwani. The session would be chaired by Dr. K.C. Loni, sir, Dr. A.S. Desai, sir, and Dr. G.P. Shah, sir. Please come.
Good morning, and today we are here for this IMA CME, and we had a very nice program. Dr. Pant and his team has done a wonderful job for doing all this. And now our next speaker is Professor R.G. Nautiyal. He is well known to all of us. He has given so many lectures to us in last many years, and we are very proud of him to be here. And today we will be discussing what is new in GINA 2023. This is the latest topic. And now I hand over you, Dr. R.G. Nautiyal. Thank you, sir.
Thank you very much, sir. At the very outset, I am thankful to President IMA Haldwani, Secretary IMA Haldwani, the organizing chairman and the organizing secretary of this conference for providing me the opportunity to be part of this August gathering. Many of you are my teachers here, basically. A teacher does not mean that he is teaching in a classroom. You teach me through your prescriptions, they come to me, your patients come to me, and I learn a lot from you people. That is the indirect teaching I am getting from you all. When I came to Haldwani and joined Sushila Tiwari, so many deliberations were made on asthma and COPD for the for our respected general practitioners over here, and I'm fortunate enough to be part of those CMEs. May I request the managers of this hall that there is a background noise, so people may not be enjoying this CME then. So what is happening on top of this? Please stop that. Thank you, Chairperson, sir. Today we'll be discussing, if you go through the report of the Registrar General of India and the report of WHO about the epidemiology of different diseases which are prevalent in the world, throughout the world and India, you see that the number one killer of mankind is among the non-infectious diseases. The first killer is ISD, that is ischemic heart disease, and the second number is respiratory disease. So we'll be talking about one of the respiratory diseases, one of the non-communicable disease, and that is bronchial asthma. Why it is important to know about this? That we will come to know within next 2-3 minutes time.
So because this was a concern or public health concern all over the world, there was a body which was established, and that body is issuing the guidelines every year. Whatever new researches are coming up, they are collecting them. They are making deliberations before their publication, and then are providing us to us those publications so that we can manage our patients carefully and optimally. That is known as GINA. So, coming to the objective of the talk is to pass on that knowledge contained in the GINA 2023 report to all our colleagues so that we may collectively offer the best to our asthma patients, to recognize the need to individualize the care of each and every asthma patient, because one shot does not fit to everyone. Different patients, they may have different need of their treatment. Then assure availability and access to effective quality assured medications. That is very important. And then to develop means to implement and evaluate effective asthma management plan to our patients. This knowledge dissemination ultimately will result into reducing the morbidity, mortality, and economic loss suffered by the patient and the country. So this is very important to know about. This has the long-lasting impact on the economy of the country also, not only to the patients. So what is this GINA? The GINA this is the Global Initiative for Asthma. GINA was established in 1993 by the National Heart, Lung and Blood Institute and the WHO with the aim of increasing awareness about asthma and providing a mechanism to translate the scientific evidence into our day-to-day practice. Annual World Asthma Day, we all know that was also initiated by GINA in 2001, and every year we are celebrating it in the month of May on the second Tuesday. Then GINA flagship publication was there, which comes to us every year to update our knowledge about asthma. Then, and it is prepared by the GINA Scientific Committee, and the GINA Scientific Committee usually meets twice in a year during the ATS and the ERS international conferences. They evaluate the researches and then put them into a publication mode so that we can get a document on that. So the GINA Science Committee has been doing annual updation on asthma management guidelines since 2002 with the changes in 2006, 2014, and 2019. Why GINA was required? We see that this diagram, if you see this one is telling something about our practices. So this figure, this photograph is enough to tell us about our practices, what we are doing. So anyone can guess what this is telling about? Anyone? This is the iceberg. Yeah, ma'am. Yeah, yeah. Much is below the water. What we are seeing in our clinical practice. Why this is happening? This is the reflection of our practices as physicians, because we are not suspecting bronchial asthma. We are underdiagnosing it. The first thing that the patient is not coming to us, they are going here and they are taking OTCs, and even if they are coming to us, we are just underdiagnosing them, because we are not putting the evidence into practice that we have to go with the pulmonary function test or something else like that. We have to take a detailed history about the disease. So this iceberg will remain there unless we are suspecting our patients with clinical features suggestive of asthma as patient of asthma and not diagnosing them and treating them. So this iceberg will remain there. So the second thing is that whatever is the guideline internationally, they may be guiding you that you prescribe these drugs. But my patient is not able to purchase that because of poverty. So there are low income countries also. That's why GINA took that also into consideration, that Guidelines may differ for US and guidelines may differ for India and the countries which are below poverty level. This is the historical background of asthma. This is a panting illness. Panting means asthma. Greek, asthma means panting. Panting means the patient is the process of taking the deep breath and all those. Beethoven's Beethoven could not be cured by his that time's best physicians in Vienna, and he landed into chronic asthma. Henry Salter, he thought he rightly pointed out that this is a episodic illness. And William Osler, in his book Principles and Practices of Medicine, told that a special form of inflammation of smaller bronchioles. This is very important, very important thing in asthma. And then came about the treatment part that Dhatura was the treatment for bronchial asthma. And on this brick, we are progressing on the inhalational therapy and the bronchodilators. Then asthma could not be defined till 1990s. SIBA first Foundation Gas Symposium was organized, and second was organized. Still then we could not define asthma. Only in GINA in 1990s, it defined asthma, what is asthma. So let us recall about asthma. First of all, what is good and bad about asthma? The good is people with asthma can live normal active life. And the bad is that asthma is not curable in any stream of medicine. I have seen patients going to homeopathy, to Machli, and to Ayurveda, and all that, ultimately coming back to us. The today morning definition of asthma, because the asthma definitions is also changing from time to time. So the today morning definition is it is a heterogeneous disease. It is chronic. It is most important thing is it involves the chronic airway inflammation and is defined by history of wheeze, shortness of breath, chest tightness, cough, symptom variation over the time and intensity, and variable expiratory L-flow limitation. Need to talk about different asthma types. What I told that one single shot does not fit to everyone. So there are types of asthma. Not all the asthma is allergic, and their responses will be different for different type of asthma. So there are different phenotypes. Allergic asthma is there, non-allergic is there. I think pediatricians are also here. So most of the childhood asthma is allergic. Non-allergic, lesser short-term response to the corticosteroids. Adult asthma is also there. It is not that if someone is in his 60s, he cannot have asthma, he will always be COPD. It is not necessary. He or she may be a case of bronchial asthma. Asthma with incomplete reversibility due to airway remodeling may be presenting like just like COPD patients. And then asthma with obesity will be a problem in India after some time. So diverse etiologies, hence different patients have different treatment needs. Then what is the ABC of asthma? You simply go through this one. A for airway hyperresponsiveness, B for bronchoconstriction, and the most important, the red one is the chronic inflammation. This is the vicious cycle of chronic airway asthma, airway inflammation, and airway inflammation, not breathlessness. Breathlessness is not the hallmark of asthma. It is the airway inflammation that is the hallmark of asthma, and this is the ultimately this cycle comes here, and a chronic stage of inflammation is developed in the airway. Query from the patients: will it disappear with passage of time? And this is, I think, this is the most right platform to tell this thing with all the scientific facts. That there was a famous Tuscan study, and that results are here. Please focus on this. If we don't have time to go through this, we cannot predict who among our asthmatics will have complete remission in future. So please don't tell them that you will be fine after some time. This may sound very good and very encouraging to the attendant of the patient, the parents of the patient, or the patient, but this is a killer. So if I don't know who will remit after some time, this means the message is very clear that we have to put them on treatment. Now, the second question is how long I have to take the therapy. So you can see the guard is there, and who is this guard? Who is this guard? The door is closed, the windows are closed. The guard is the physician. We have to make all such arrangement for our asthmatics, that the therapy has to be given lifelong. Then GINA guidance for confirmation of asthma, we all how we make out the diagnosis. We go to the first one, that is enough to say that if the post bronchodilator, the second one, documented variability. Okay, yes. First one is documented expiratory airflow limitation. FEV1, FVC is reduced compared to lower limit of normal, that is more than 0.75. It is if it is less than zero point 0.7, it is COPD then. But if it is more than 0.75 to 0.80 in adult and more than 0.90 in children, it is suggestive of asthma. Then the post bronchodilator reversibility in FEV1 by more than 12% and 200 ml, that is also diagnostic of bronchial asthma. We have given the figure for the children also. What we know about treatment of asthma so far? It is a disease of spasm. The airway constricts. It is a disease of swelling of the airway that is secondary to inflammation. And for relieving that, we need beta-2 agonists. We have with us the short-acting and the long-acting beta agonists. And to reduce the inflammation and the edema, we have corticosteroid. One thing about corticosteroid, everyone is afraid of using it. So the science, what does the science say? That is in the second one. The only drug for regular use. Even when your patient is completely asymptomatic, you have to administer this because the asthmatic airway is absolutely different from the normal airway. Even when the patient is not experiencing any symptom, the inflammation cascade is going on and it is preparing for the next season, waiting for the trigger to come. And that time your patient will land up into emergency and will have to be admitted in the ICU. So this is very safe. Up to 9 years of regular use of 400 microgram of budesonide used in children, there was no retardation in growth and there was no HPA suppression. Rather, if you don't use steroid, growth retardation will take place because their brain will not develop, their body will not develop due to persistent hypoxia. Then GINA has revised the asthma medication terminology. I am not going into the detail. I have already told you that the reliever and the preventer, that is the most plausible still, but they have uh, decided that we have to remove the confusion from the terminology, and they have given this new terminology. You can go through the document. Then you see that what is high dose, what is low dose, and what is medium dose steroid, that is shown in this table. I am skipping it. You can go through it. Then enough have now focused that one shot does not fit to everyone. That's why GINA has issued the personalized control-based asthma management cycle. So they focused on you just assess correctness of diagnosis, whether my diagnosis is correct, whether symptom is adequately controlled, whether what are the risk factors for exacerbation and decline in lung function, what are the adverse effects of medications, whether the patient is taking the inhaler correctly, whether the patient is compliant to the treatment, what are the comorbidities like obesity is there, and then what is the patient's goal and preference, what does the patient want from us, then adjust the treatment accordingly after assessing these factors. And then during the subsequent follow-ups, we review the progress. This is the GINA personalized management for adults and adolescents 12 plus years. Unfortunately, the division between the adult and the pediatric is I think 18 years, but it is like this. I'm sorry. So I'm skipping it. What is here is that formoterol as ICS and budesonide, they are the most extensively studied drugs. This is the guideline for children 16 to 11 years of age, and this is for 5 years and younger. Everywhere you have to use one single thing, that is formoterol. That is your steroid and a long-acting bronchodilator, that is formoterol.
Yes. Which device has to be used? So best device is this PMDI with with ये काम नहीं करता है क्या इसमें? This PMDI with valve held chamber, which is non-electrostatic. So we have to give them one good spacer. That is best rather than giving them the capsule, rotacap form. So there are many definitional terms. I'm not going through them. Then now coming to the very important thing, what is the advancement in the, now we are talking about the precision therapy in bronchial asthma. And these are various drugs, their doses are written there. You can take this presentation from this place. I have uploaded this on the system. And but these biological therapies, they are not the substitute for the are inhaled steroid and inhaled beta agonists. They are the add-on therapies. The first thing with them is most of them, they are expensive. Our patients may not afford them. Then we are managing the asthma exacerbations and the severe form of asthma. That new addition is there, that we are in a haste to go for magnesium and all those. One very important message from this slide is, sir, 1 minute only. One very important message from this slide is, please forget Dexona and derifylin now. It is clearly written over aminophylline, theophylline, routine antibiotic, helium oxygen therapy, they are not recommended now. IV magnesium is also not recommended routinely. So the best thing is we have to give them formoterol and budesonide, which is extensively practiced. Then a small thing about the safety and reliability of pulse oximetry. So pulse oximetry is completely misleading. Please don't stick on that. Your patient is getting 92% of oxygen saturation. This does not mean that he or she has 92. It may be well below that. So FDA has issued the caution directions to the practitioners. Please don't rely on the pulse oximetry. Then imaging helps in differential diagnosis, but not for the diagnosis of bronchial asthma. Then INA has added pertussis in the differential diagnosis. Now this is the new addition, and GINA caution against the FeNO also. The fractional concentration of azidic nitric oxide guided treatment. This is also fallacious and this is also misleading. Please don't depend on FeNO for the diagnosis and monitoring of the treatment. Then rhinitis and sinorhinitis. If you give treatment for that, this does not mean that the asthma will also be controlled with those medications. They will control only the nose. And then the non-pharmacologic studies, aerobic exercise, that panting and all those things, they are not helpful. Sometimes they may be your क्या बोलते हैं उसको जो करते हैं हम लोग अनुलोम विलोम. Frictional injury will take place and that will further damage the airway and inflammation will increase. Then the outdoor air pollution. अगर आप इनहेलर ले रहे हैं तो कोई करने की जरूरत नहीं है. नहीं ले रहे हैं तो आपको अपनी खिड़की दरवाजे वैसे ही बंद रखने हैं जैसे अभी बताया. And vaccination is important. वो ये कहते हैं कि जो हमारा COPD का vaccination schedule है, that is different and this is different. Here influenza viral vaccine is indicated, but the pneumococcal vaccine and the pertussis vaccine is not indicated in bronchial asthma. The role of immunotherapy की बहुत सारी मैं देखता हूँ कि वो आता है कि अखबार में आता है कि आप अपना टेस्ट कराए एलर्जी. That is completely and completely a business. So role of immunotherapy in India is questionable. The take home is airway inflammation is central to understand asthma and hence treatment of asthma with ICS is without ICS is unscientific. In fact, it is the ICS which has changed the life of asthmatics. It is not acceptable in 2023 to manage asthma with acetylene inhaler or oral corticosteroids. Budesonide and formoterol combination is the most widely researched combination for treatment of asthma in adults and children. And whenever possible, this benefit should be transferred to the patient. Poor patient who cannot afford the cost, ICS, budesonide or your fluticasone, they should be prescribed whenever they take the short-acting like acetylene inhaler for symptom relief. And then the biologicals are the precision medications which will be used in appropriate setting, but these are add-on medications and not substitution to the budesonide and formoterol therapy. Thank you very much, sir.
Thank you very much, Dr. Nadir, for your concise and comprehensive lecture on asthma. If anybody has any questions?
वो दो माइक दो ना यार, बैठो नहीं, इस समय एक्टिव रहना ना सर, माइक ली.
So nearly every prescription has a combination of leukocytrazine and montelukast, but you have to for that.
सर देखिए, अभी जो नए कुछ रिपोर्ट्स आए हैं जिसमें अगर मोंटेलिकास्ट को आप ज्यादा दिन यूज करते हैं तो मेंटल डिसऑर्डर्स आर नोटिस्ड इन चिल्ड्रन. प्लीज बी कॉशियस अबाउट दैट. दे आर डेवलपिंग द मेंटल डिसऑर्डर्स देन. तो हम उसको नहीं कर रहे हैं. उसको हम एलर्जिक राइनाइटिस एंड राइनोसाइनोसाइटिस होता है, शॉर्ट टर्म में देते हैं. उसके बाद आप उसको नेजल स्प्रे दीजिए. आप मोंटेलिकास्ट को यूज नहीं करेंगे ज्यादा. देयर आर रिपोर्ट्स नाउ. And particularly if you are giving it in children, this is a message to the pediatrician. Please avoid that combination. And go through the literature, see that this montelukast, what it is doing with the children.
Sir, in the beginning, this montelukast was supposed to not to write these children's.
Yes, sir.
And after some time, people started using them. But when it was started, I remember well, it was not indicated in children.
Yes. Sir, basically होता क्या है कि जो मार्केट होती है वो बिजनेस फोर्सेस से भी डायरेक्ट होती है. And unknowingly we also become the part of that. लेकिन अगर कोई साइंटिफिकली आ रहा है, और आज के हम एक भी मैसेज यही ले जाएं कि किसी के बच्चे को हम मोंटेलिकास्ट नहीं देंगे. अब आप उसको उस पे रखिए ना, नेजल स्प्रे पे रखिए. जो जिस एज ग्रुप में जो नेजल स्प्रे इंडिकेटेड है उसको रखिए. You can give levocetirizine plain. Yes, for the time being. And if at all you want to give, तो लॉन्ग टर्म के लिए नहीं देना है. आप शॉर्ट टर्म के लिए मोंटेलिकास्ट लेवोसेट्रिजिन दे सकते हैं. आफ्टर 21 डेज के बाद क्या होता है कि एलर्जिक कास्केट थोड़ा सा पीसफुल उसमें आने लगता है. उसके बाद आप उसको स्विच कर लीजिए नेजल स्प्रे पे.
Thank you, Dr. Nadir.
Thank you.
Thanks to the audience also for your informative and nice talk.
I'm sorry for the delay also, because this was not so simple to tell about. Thank you very much, sir.
Thank you, sir, for a very informative talk on a very difficult topic and a topic which has a lot of new and emerging trends. I would like the chairpersons to felicitate the speaker. Sir, please. A little round of applause, please. And I would like to call Dr. K.C. Sharma, sir, to felicitate the chairpersons, please. Without a further ado, let's welcome our next speaker, Dr. Varun Verma, Associate Director, Nephrology, Max Super Speciality Hospital, Parpaga. The topic of discussion would be continuous renal replacement therapy in critical care. And I would like to invite Dr. Trilochan Singh, sir, to chair the session with Dr. A.S. Son, sir, and Dr. Ajay Kumar Jain, sir. Sir, please. Dr. A.S. Son, sir. Thank you.
Hello. Yes. Good morning, everyone. Now I invite Dr. Varun Verma, sir, Max Hospital, Patparganj. Topic is ERT in critical care. Now, kindly start the session.
Uh, Good morning, and thanks for inviting me to give this talk. So I'll directly start the topic, which is CRRT. So let's start with the basic. What is CRRT? It's also known as the slow continuous replacement therapy. It's basically any extracorporeal blood purification therapy which is intended to substitute impaired renal functions over an extended period of time. In short, it is just a dialysis which can be done for days, hours, even weeks. Let's look at the features of CRRT. So, what are the benefits of CRRT? First of all, it's an efficient solute clearance system. When you connect your patient who is hemodynamically unstable, who cannot tolerate any form of dialysis, you connect the patient to this machine and then you can change the internal milieu of the patient. For you can correct their sodium, you can correct their potassium, you can correct their bicarbs, you can correct acidosis, you can settle down their serum creatinine, and not only that, urea creatinine basically small molecules. Their size is about maybe 50 daltons and 150 daltons. But what about the other molecules which are larger, bigger, 80,000 daltons, 20,000 daltons? These cannot be cleared by routine dialysis. These can be taken care of by CRRT. I'm talking about myoglobin, which is very common, rhabdomyolysis. The therapy is extremely gentle on the body. So, vasopressin, adrenaline, noradrenaline, they are going on in the patient. The patient's blood pressure is still in 80s and 90s. It can even be softer than that. But still, the dialysis can continue forever. You can continue to infuse uh, uh, TPN, TSRI. You can take care of the nutrition at one end, and you can keep on removing that amount of fluid at the other end. The hemodynamic stress is very less on the body. So overall, it's a very good system. In short, it is just like an artificial kidney which comes to the rescue when your native kidneys are gone and when other dialysis modalities cannot be used. So let's talk about the basic principles. The first principle is ultrafiltration. So what is ultrafiltration? Look at this diagram. There's a membrane. So what you're doing is on this end, there is blood. So you have a hollow capillary which is housed in a cylinder, and the blood is running in those capillaries. And outside the capillary, there's nothing. So you just apply some suction and you start removing fluid. So you are removing fluid at a rate of maybe 100 ml, 150 ml. This is the first principle. This is ultrafiltration. You are not doing any changes in the internal milieu of the body. You're just removing water from the system. This is the second principle is diffusion. Diffusion, in short, it's just the natural movement of the molecule. If you ignite an incense stick, an agarbatti at one end of the corridor, the aroma of the agarbatti it spreads by itself. Now that is diffusion. So similar principle applies in dialysis. The red part is the blood. The other part is your water, your dialysate. The blood is again running in a capillary, and the blood is running from top to bottom, and the dialysate is running from bottom to up. You can plan the electrolyte concentration of your dialysate as per your own choice. You can keep a sodium of 130, 145, or even 120 according to the need of the patient. You can keep the potassium as per your requirement. Now, the molecules, the high urea, creatinine, middle molecules, cytokines, interleukins, they simply diffuse across the membrane and they are trapped by the dialysate and they are taken away. So, this is the second principle. The problem with this principle is that only lower molecular weight molecules can be taken care of. Next is conviction. So, what is conviction? Um, if, Again, let's go back to the which was lit at the end of the corridor. It was the aroma was spreading by itself. Now, what if you connect a fan to the other end? So what happens is the aroma spreads rapidly. Now, that is convection. Now, how do you use it on dialysis? Again, let's go back to this diagram. This is blood and this is dialysate. If you start infusing water, plain water, highly pure water. Again, the milling of the water is as per your choice. Sodium, potassium, chloride, bicarb, you choose it by yourself. You infuse water at a high flow, let's say 1 liter per hour, 2 liter per hour, at one end of the dialysate, at one end of the blood, and the water it drags into the dialysate chamber, and while it is dragging away, it carries away all the molecules, it carries away all the toxins. The advantage is you can take care of larger molecules. You can even take care of myoglobin, which is very large and not removed by routine dialysis. So this is convection. Uh, can you club these modalities? Can you have both diffusion as well as convection? Yes, you can have them both, which we call hemodiafiltration. So at one end, you have dialysate. This is your blood running in a capillary. This is your dialysate. The dialysate, you have a dialysate which is clearing the molecules by osmosis. You're also infusing water, highly pure water at one end, which is dragging away all the solutes, and you're getting better clearances. There's one more mechanism which is very interesting. This is adsorption. So there is no dialysate. You have a capillary. The capillary lining is it's lined with adsorption molecules. You can have polymyxin B, which absorbs cytokines, interleukins. You can have antibodies. You can remove antibodies. You can line the capillary with antibodies. So what happens is you can take care of cytokine storms, interleukin storms, and it removes all the toxins. You can also remove bilirubin. You can remove poisons also. So this is another addition to therapy. And absorption is used quite frequently in settings of sepsis, particularly gram-negative abdominal sepsis. So what are the modes of dialysis? The first one is which is just slow continuous ultrafiltration. Second one is continuous veno-venous hemofiltration. Third one is hemodiafiltration, and third one is hemodiafiltration, which is combination of all the therapies. So let's take a look at this diagram. So you have this, this is the dialyzer. Blood is being brought to the dialyzer by a tube. The blood is running in capillaries, and there is the capillaries are housed in a plastic. You are simply removing water, continuously removing water. Earlier, what we were doing, you would simply connect the dialysis chamber to a routine ultrafiltration machine, a routine suction machine, and we would start removing water from the body. A patient who has CHF, a patient who has simple volume overload, we can remove 1 liter at a go, continuously. Patient is able to avoid going on a ventilator. Uh, Now, hemodialysis. So this is just hemodialysis, wherein you have, but this is a continuous hemodialysis. So blood goes into the membrane, it comes out at the other end. Dialysate goes at the opposite end. It removes impurities by simple osmosis. You connect the patient and you continuous hemodialysis for 24 hours, 48 hours, 72 hours. Uh, this is hemofiltration, just hemofiltration. There's no dialysate. So the difference is that the you are infusing water at one end. This is the arterial end. The water goes into the system, into the capillary. The water pours out in the dialysate chamber, and it is removed. You can infuse water before the blood enters the dialysate chamber. You can infuse blood after it comes out of the dialysate chamber. The advantage uh, of pre-filter dilution, we call it pre-filter dilution. If you are infusing blood before the blood enters the dialysate, you can infuse the blood post-filter also. The advantages are that more efficient removals are possible, and less clotting happens. We can club these modalities, which is called hemodiafiltration, where you are infusing blood at one end and you're also running dialysate at the other end. You get better clearances. You remove all the larger molecules also. Now, are there any other modalities which used for AKI in a patient who is in sepsis, who is in ICU? Yes, we have hybrid therapies also. So let's compare those hybrid therapies with our CRRT. Uh, the first hybrid therapy which we can discuss is extended daily dialysis, or slow low efficiency dialysis, or slow low efficiency daily dialysis. So what happens is these are just dialysis machines. You connect the patient dialysis machine and you dialyze them continuously for 6 hours, 8 hours, 12 hours, 48 hours, 24 hours. You can extend it even further. But the disadvantage is that these are only convection-based therapies. They have very little. They are just osmosis-based therapies. They're not convection-based therapies. Number one. Number two, the patients who are critically ill in ICU sometimes are not able to tolerate these therapies, which patients who are on CRT can tolerate better. Uh, then can't we do simple routine dialysis on these patients? We can do that, but again, the problem is hemodynamic instability. So CRRT comes into play when a patient is critically ill, he's on multiple pressors and cannot tolerate any other modality, where we can clearances over extended periods and achieve results. So let's look at what are the KDIGO guidelines. So the first guideline is very interesting because RRT is not actually use of continuous intermittent RRT as a complementary therapy in AKI patients. Now this is not graded, so which means that the KDIGO doesn't support use of RRT in AKI patients. But that's not true. It depends upon which condition you are using the patient. CRRT is to be used rather than standard RRT for patients who are hemodynamically unstable. So this is the first recommendation, but this is class 2B recommendation. CRRT rather than RRT, which is routine hemodialysis for AKI patients, would be beneficial in patients who have brain injury. So because uh, hemodialysis, the changes are rapid. In CRRT, changes are very slow. So cerebral edema is less common in patients who are undergoing CRRT as compared to other therapies. Similarly, if patient has increased intracranial pressure, CRRT is more gentle. This is where the recommendation is. Now let's look at the modalities where you can use them, like scuff. So in case of heart failure, you can they have actually invented machines who did not have any dialysis. They were just removing water. We call them scuff machines. They were used for heart failures. Then you can do liver dialysis with we call them albumin single pass albumin dialysis, where a patient with hepatic failure, you have a patient with hepatic failure with very high bilirubin, and March is not an option because it's not available. We can use CRRT as a skip as a mechanism. It's as an intermediate mechanism towards a liver transplant. In all immunoglobulin or collagen vascular diseases or immune mediated diseases, CRRT is a boon. Move those antibodies continuously and achieve good results. We can also use CRRT with, for carbon dioxide removal because there are chambers which specifically remove PCO2 and help in exacerbation of COPD. So let's look at the clinical indications of CRRT. There are renal indications, which are simple acute renal failure, azotemia, fluid overload, tumor lysis syndrome, sepsis, and cerebral edema. Now, these are classical indications. But there are certain non-classical indications like drug overdose, metabolic injuries, crush injuries, sepsis, ERDS, fluid overload, congestive heart failure, autoimmune disorders, and even cytokine storm syndromes, where CRT has been found to be quite beneficial. Let's look at role of CRT. Now let's look at the role of CRT in various situation. So in sepsis, you have cytokine, TNF alpha, IL-1, IL-6, IL-8 storms. These molecules cannot be removed by dialysis. You attach your patient to a CRT machine for next 4 days or 5 days till the sepsis and the septic storm settles down. And you're continuously removing these large molecules, and it helps in achieving more hemodynamic stability. Patients who are septic and who are having septic shock, they have excess of fluid, they need filtration, they need waste or product removal. Their acid base balances need to be taken care of for days altogether till the body fights back and the patient can be extubated. The other modalities are cardiodepressant. This modality is not, and of course temperature. Patients who have high blood temperatures, temperatures are in 104, 105. You can take care of the temperature also with CRRT. Uh, Now let's talk about diuretic wasting CHF, which is another indication for CRRT. a patient with a CHF not responding to diuretics, you simply connect the patient to a CRRT machine and you continuously remove the water. You can remove water at a rate of 100 ml per hour, 200 ml per hour, 300 ml per hour till you achieve your results. It's a very good modality. There are machines which are programmed just for ultrafiltration. They were used earlier in US and other countries, uh, but they are not available in India, and you can simply achieve the same results with CRRT. Now let's talk about ARDS. So the major challenges of ARDS are acid-base balance, fluid control, electrolyte balance, and toxins, which are better taken care of by CRRT. Rhabdomyolysis, again, large molecule myoglobulin, it's better removed by CRRT rather than hemodialysis or SLED. In hepatic failure, now this is interesting. Patients with hepatic failure, they have low blood pressures, they have ascites, they have coagulopathy, they have elevated bilirubin, they have dyselectrolytemia, they have multi-organ failures, and they have cerebral edema also. So CRRT being gentle, it helps in all these in achieving results in this particular situation. Moreover, single pass albumin dialysis, wherein what you do is you simply add albumin to the dialysate. The dialysate is now being rich in albumin, while going across the membrane, it sort of absorbs these floating bilirubin and carries it away with it. So your bilirubin goes down, your ammonia goes down, patient starts improving. But again, this is just a stopgap mechanism, a stopgap arrangement towards a liver transplant, or you have a fulminant hepatic failure where eventual recovery can happen. Autoimmune disorders is again another indication for CRRT. Antibodies, monoclonal proteins like multiple myelomas, the toxic factors, circulating immune complexes, they can be removed by specific directed adsorption columns. Uh, Cytokine storm syndrome is it's a very good, particularly HLH, hemophagocytic syndromes, infections like influenzas, Epstein-Barr virus, cytomegalovirus, gram-negative sepsis, SARS, AIDS. These modalities help in controlling cytokine storm in these situations and help in achieving good results. Thank you.
Thank you, sir. Now the session is open for discussion.
Thank you, sir.
So you said it was used for cytokine storm.
Yes, sir.
Was this modality used during COVID also?
It was.
Was it?
It was used extensively, but the results data is not very clear. It was used, and then whenever we are in a state of emergency, you throw everything at the patient. It's pretty expensive. Initiation charge will be something 18,000 for the dialyzer. This machine is also expensive. It costs about 25 lakh. The major cost of therapy is the dialysate bags. It's almost 5,000 per bag. So if you are doing high flow dialysis, you end up with doing, the patient starts paying about 50,000 to 60,000 per day for CRRT. But again, in life-saving situation, it's still worth it.
Any more questions? Any more questions from the audience? So it's very rightly said that it's not only the topic. The more important is that who is presenting the topic. Sir, we congratulate you for the ultimate justice that you have done to this topic today.
Thank you, sir.
Because it's a very important modality which is being used in tertiary care centers, I think. So thank you so much. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir. I would like to call upon the chairpersons to felicitate the speaker, please. A little round of applause, please. Active participation from the audience is needed. I request Dr. Filoria sir to be present on the dais to felicitate the chairpersons. The next topic of discussion is approach to resistant hypertension, and the speaker is Dr. H.S. Bhandari sir, Director Nephrology, Central Hospital, Haldwani. The chairpersons for the session are Dr. Rajiv Kumar Mahajan sir from Gadarpur, Dr. Manu Mahajan from Kashipur, and Dr. Hansa sir from Bajpur.
कैसे आ गए? Start, please. Thank you very much. Good morning to all my seniors, and I welcome all the dignitaries and the delegates and faculty coming all the way to Haldwani on the behalf of IMA Haldwani. Today, I will not talk about the mild hypertension, which can be controlled by one or two drugs. Today, I will talk about the resistant hypertension only. By definition, blood pressure that remains above 140 by 90 millimeter of mercury, despite use of three antihypertensive medications of different classes in maximal dose, and one of them must be the diuretic. This is the actual definition, and there is limitation of the definition because non-uniformity of the prescription. We have many drugs, and we are prescribing on our own because of the basic patient underlying heart failure, renal failure, like that. So there is no uniform prescription. So it is very difficult to have a uniform prescription. The possible causes of resistant hypertension is patient resistance, physician resistance, drug interaction, then excessive salt intake, office hypertension or pseudohypertension. Then comes the secondary cause of hypertension. After dealing with all of these causes, then we left with true drug resistant hypertension, which is only 2% of the cases of the resistant hypertension. These are the contributing factors of the resistant hypertension. If we see this slide, the main cause is suboptimal therapy, which is because of the physician resistance. And the second cause is drug intolerance, secondary causes, non-compliances, psychiatric causes, and office hypertension or pseudo-hypertension. So if we improve on our part, then there is lot of scope to control our inadequate adherence to therapeutic regime, and this takes exhaustive dietary history of sodium intake, obesity, alcohol consumption, then whether the patient is taking the prescribed drug or not, and we have to see whether we are prescribing the actual dosing schedule or patient is taking them or not, and along with the substance abuses like alcohol, cocaine, amphetamines. In patient non-compliance, there are other techniques also, laboratory techniques also. We can monitor 24-hour urinary sodium or drug levels in cases where we find difficult to understand whether the patient is compliant or non-compliant. The second step is to see whether we are prescribing the rational triple drug regime or not. The rational triple drug regime is diuretic, sympathetic inhibitor, and vasodilator. In vasodilator group, we have hydrogene minoxidil, which is direct arterial vasodilator, and another are ACE inhibitor and ARBs, which in addition controls renin angiotensin system also, and direct renin inhibitors calcium channel blockers. In sympathetic blockers, beta blockers, alpha blockers, prazosin, and central acting sympatholytic drugs like clonidine, aldomet, labetalol. In diuretics, there are thiazide, thiazide-like diuretics, loop diuretics, and potassium-sparing diuretics. So what is not resistant hypertension? This is the two regimes. In one, patient is taking hydrochlorothiazide 12.5 milligram once a day and hydralazine 25 milligram BD, metoprolol 25 milligram OD. If we look superficially, look that patient is taking different classes of drugs and still if blood pressure is not controlled, we can say that it is a resistant hypertension, but actually hydrochlorothiazide dose is 12.5 milligram, and that too OD. The actual dose and the maximal dose of hydrochlorothiazide is 50 milligram, and hydralazine here given in BD dose, it should be given PDS or QID, and the maximal dose is 200 milligram. Metoprolol maximum dose is 100 milligram. So this is inadequate regime. We cannot say in this regime that patient is a case of resistant hypertension because of inadequate dose and inadequate scheduling of the drugs. Similarly, in second regime, patient is on Cardes 5 milligram OD. The maximum dose of ramipril is 10 milligram. Lasix 40 milligram OD. Now this is important. It do more harm than benefit. Lasix lasts for 6 hours only. Its duration of action is 6 hours. During this 6 hour, patients pass lot of urine and there is control of BP definitely. But after that, the patient develop negative salt and water balance and start reabsorbing salt and water in the later 16 hours to 18 hours because of the activation of the renin-angiotensin system. So Lasix do harm if we give in OD doses. We can give them in twice dose at least or thrice dose. We can break these medicines and preferably we can use chlorothiazide, hydrochlorothiazide or diuretics like torsemide, which has a long life. Nicardiaxel, again the dose is 30 milligram. Here the dose is inadequate. So these are the regime which are inadequate. So what is the adequate regime? In oral diuretic, a dose equivalent of 50 milligram of hydrochlorothiazide, 10 milligram metalazone, 25 milligram chlorthalidone, or 5 milligram indapamide. In sympathetic blockers, important one is clonidine 0.8 milligram. Clonidine has a peculiar effect, withdrawal syndrome. Whenever we stop the clonidine, there is withdrawal syndrome, rebound hypertension. So care must be taken while prescribing clonidine. In vasodilator, there are hydralazine, minoxidil, ACE inhibitor, ARBs. In regime 1, the third part is vasodilator, directly acting vasodilator, hydralazine and minoxidil. In place of them, we can use calcium channel blocker or ACE inhibitor or ARBs. The second most important cause of suboptimal therapy is not addressing the issue of volume overload. Because of the inadequate diuretic therapy or excess sodium intakes, which fails our diuretic therapy, or there is fluid retention and salt retention secondary from hypotension or progressive renal damage. So these two are the main causes which we can improve and we can control at least 50% of the resistant hypertension cases if we control the volume overload and give the optimal therapy in maximal doses. This is to understand why this is happening. Diuretic, the action is negative salt and water balance, and counter action to control this so that it is feedback mechanism. Our all is stimulation of renin-angiotensin system. Similarly, with sympathetic inhibitors, the action is sympathetic block and counter action is fluid retention. The third is vasodilator. It decreases peripheral resistance and counteraction is increase in cardiac output, fluid retention, and stimulation of renin-angiotensin system. The treatment, what is the treatment? Mechanism, if the mechanism is fluid retention because of the sympathetic inhibitors or vasodilators, the treatment is diuretic. If it is cardiac stimulation because of the vasodilator, then next drug we should add is beta blocker. If it is renin activation of renin-angiotensin system, because of the diuretic or vasodilator, the next drug we should add is sympathetic inhibitors, ACE inhibitors. If these we add the counteracting drugs, then it will is more effective than any other drugs while controlling the BP. After taking these two steps, the third is to check the drug action and interactions. Whether the patient is taking any over-the-counter drugs, nasal decongestants, sympathomimetics, appetite suppressants, cocaine, caffeine, oral contraceptive pills. Nowadays, the dose is very less, so it is not the main cause, but occasionally we can get the case where OCP can be the reason for resistant hypertension. Adrenal steroids, licorice, cyclosporin and tacrolimus, which is transplant medicines, erythropoietin, antidepressant, and very important anesthetics. If patient is taking any of these medications, we need to remove these medicines before moving further. And after this, my approach is to rule out the pseudo hypertension or resistant or the white coat hypertension. It is suspected in patients which have very high indirect BP but no target organ damage. Target organs are kidney, and kidney and heart. We can check by retinopathy or by the urine proteinuria or serum creatinine. In pseudohypertension, it is due to the stiff brachial artery. It is seen in elderly. It is because the cuff pressure required to compress the atherosclerosis artery is much higher than the actual BP inside the artery. So pseudohypertension can be diagnosed definitely if we put the invasive intra-arterial BP monitoring. Some earlier in our medical teaching, oscular maneuver was also told to us. After, and the second is white coat hypertension. It is the discrepancy in office where the BP is very high, and when we do the home BP or ambulatory BP monitoring, it is usually well controlled. The major cases where we suspect these when there is no target organ damage and there are symptoms of overtreatment. Example, patient is having postural symptoms or patient is feeling very fatigued. The technique of BP measurement is we all learned in our MBBS, 5 minutes of rest, no conversation, seated comfortable, arm should be at the level of the heart, and there should be no tobacco or caffeine intake in preceding 30 minutes. Two seated reading and two upright reading should be obtained and averaged, and it should be taken over the bare arm, not over the sweater, not over the coat, over the bare arm. We all know that it is difficult to take it into our routine practice, but in cases of difficult hypertension, we can practice this type of BP measurement. After ruling out all these things, where the patient compliance, suboptimal dose, volume overload, and drug interactions and pseudo hypertension, vital coat hypertension, if BP is still high, then we should look for the secondary causes, which accounts for 10% of the cases of resistant hypertension. The causes are here: renal parenchymal disease, renovascular, primary aldosteronism. Earlier, it was thought only 0.3%, but nowadays, because of the improvement of technique or anything else, now the diagnosis is coming up very rapidly of primary aldosteronism, which is around 3 to 5%. Pheochromocytoma, hypothyroidism, hyperparathyroidism, and Cushing disease. The secondary disease is difficult to diagnose. It is difficult to guess it because we are routinely dealing with the patient in 80% of the cases. We control the BP without thinking about the secondary causes. And so it is in our habit that we ignore the secondary causes. And secondly, it is sometimes very difficult to diagnose secondary causes because the imaging technique and the biochemical assay we need is not available routinely, or we cannot judge it accurately because we are not doing it routinely. In which cases we suspect atypical hypertension? If the age of onset is less than 20 years or more than 50 years. If the level of BP is 180 by 110 millimeter of mercury, there is evidence of target organ damage, fundus, serum creatinine, LVH. There are some specific features also, like unprovoked hypokalemia in case of primary or secondary aldosteronism, variable BP with tachycardia, sweating, and tremors. There is family history of kidney disease, family history of hypertension. In those cases, uh, where because of the hypertension, patient has developed some intracranial hemorrhage or stroke, in those cases, we can look for the secondary causes. Individually, renovascular hypertension is uh, accelerated malignant hypertension. Patient comes to the hospital with history of flash pulmonary edema, suddenly went into the heart failure and attend our emergency. And there is unexplained deterioration of renal function or during therapy with ACE inhibitors. The presence of systolic or diastolic abdominal grooves are additional clue, but the test is ultrasound, CT angio, MRI angio, or angiography. But these tests are not actually telling us whether if we do the intervention, whether patient will get benefit or not. For that, we need to do captopril suppression test. So captopril suppression test is not easy to do. That's why we usually skip in our OPD. They need to be sent to some hypertension specialist. Primary aldosteronism in cases where is unprovoked hypokalemia, patient on any diuretic. There is hypouricemia because of volume expansion and metabolic alkalosis. We can confirm it by high urinary potassium excretion. We can calculate trans-tubular potassium gradient. If potassium is more than 30 milliequivalent, and we can use serum on urine osmolality to calculate this. And if it is PPKG is more than 4, then the chances of primary aldosteronism is high. Somehow, obstructive sleep apnea is commonly associated with it. The biochemical assay, plasma aldosterone to plasma renin ratio, is required for diagnosis before doing any imaging study. The causes are adrenal adenoma, carcinoma, or hyperplasia. But before doing imaging, biochemical imaging is must because these adenoma or any mass can be present there without any excess production of aldosterone. So before labeling them primary aldosterone, it is necessary to do aldosterone to plasma renin ratio. Pheochromocytoma, paroxysmal hypertension with headache, tachycardia, palpitation, tremor, and sweating, history of labile BP, and recent weight loss. And very important is whenever patient is taken for anesthesia, there is pressure response. Patient become very hypertensive if we do not give alpha blockers to them. It is a refractory hypertension, occasional occurs with neurocutaneous syndrome, multiple endocrine neoplasia like VHL, unusual lability of BP of orthostatic hypertension, and one additional clue is there is abnormal glucose tolerance. And of course, the diagnosis is by plasma measurement of catecholamines and urinary measurement of catecholamines. The important thing is that this elevated plasma catecholamines, more than 2000 picogram per ml, is not suppressible by clonidine. Renal parenchymal disease, we all know proteinuria, hematuria, renal insufficiency, easy to diagnose. Thyroid, systolic BP is high, hypothyroid, diastolic BP is high, and hyperparathyroid is rare cause, very rare cause, but hypercalcemia, polyuria, polydipsia is a clue. If after ruling out the secondary causes also, we are not able to reach whether the patient is having with what kind of hypertension and control the BP, then we can for neurohormonal aberration, we can do plasma renin activity, aldosterone, and plasma catecholamines. If plasma renin activity high, we can beta blocker, ACE inhibitor, or therapies. If aldosterone is high, we can give aldosterone blockers like Baxdrostat, which is newer drug, and spironolactone and eplerenone. If the plasma catecholamine is high, it is usually in the range of 800, but it is suppressible by clonidine. So clonidine can be given as a treatment. Finally, how to approach? First, we have to see whether the patient is compliant. If patient is non-compliant, then we have to deal with it. If after dealing with it, if we found that everything is all right, then we have to check whether the regime is adequate or not. Patient is taking optimal dose and we have taken care of plasma volume or not. If we do all this and still if BP is uncontrolled, we need to see the drug interactions. Uh, if there is no drug interaction, or then we have to see whether we are dealing with true hypertension or pseudo or white coat hypertension. If patient is not having any pseudo hypertension or white coat hypertension, then we have to rule out the secondary causes or we have to see for the secondary causes. And even after that, if BP is not controlled, we can change regime empirically. Suppose we are giving 3 drugs and we diuretics, sympathetic inhibitors, and lastly vasodilators. Suppose we are giving uh, minoxidil or we are giving hydralazine, which is directly arterial vasodilator. Then we can add another drug like which can suppress renin-angiotensin system or vice versa. And if BP is uncontrolled, then we have to we can check the neurohormonal aberration and alter the regime appropriately. If patient is having adrenaline high or renin high or aldosterone high, we target our therapy. Thank you.
Thank you, sir, for such an informative talk and something which we face regularly in our clinical practice. I think all of us will agree is resistant hypertension of some kind or the other. Very good to know that only 2% is the real resistant hypertension. I'd like to invite the audience if you want to ask any questions, please.
If aldactone is not the part of regime for refractory hypertension.
Yes, sir. In diuretic therapy, aldactone, it is potassium sparing diuretics. It is very effective. We can give it once a day dose also. Aldosterone, trimetrine, amiloride, and eplerenone, these all can be given. And now a newer drug, baxdrostat, which is direct aldosterone inhibitor, is also in final stages, and it is very effective. It, in cases of resistant hypertension, it is seen that it can lower the BP by more than 10 millimeter of mercury over placebo. It is seen that. So spironolactone is very good drug. We have to take care of the hyperkalemia because hyperkalemia is sometimes very life-threatening, can cause cardiac arrest also. So, but aldosterone is very good drug. In addition to controlling the BP, it's also like ACE inhibitor and ARBs. It inhibit the fibrosis of the heart, favorable remodeling of the heart and kidney. So it's actually a very good drug. Pardon, sir, please, sir. आवाज नहीं आई.
You have not included coarctation aorta, renal artery
Yes,
stenosis.
yes, yes, sir, you are right.
Because they are also very important.
No, definitely,
We are
definitely.
treating the patient and he's not getting all right.
Coarctation of aorta is also, sir rightly said, is also one of the cause. Coarctation of aorta is easy to diagnose because there is coarctation of aorta, there is differential blood pressure in the upper and lower limb. Lower limb usually no blood pressure, sometimes absent or pulses. Coarctation of aorta is usually while doing the echo, we can diagnose them. And renal artery stenosis, I included it. And in renal artery stenosis, uh, I have included there are 2 causes actually: fibromuscular dysplasia and atherosclerosis. If patient is young, female, particularly less than 30 year of age or near 30 year of age, then fibromuscular dysplasia is the cause. But patient is having sometimes and no, not any hypertension or low hypertension and suddenly become uncontrolled hypertensive. Then there is secondary atherosclerosis in the renal artery, and that can also cause renal artery stenosis. And renal artery stenosis we can diagnose with the help of ultrasound Doppler, CT angio, MRI angio, or angio. But whether we do the relieving surgery, whether we should remove the stenosis or not, because it said that more than 80% if there is stenosis, it is critical stenosis. But most of the patient do not get benefit by dilating it because the underlying mechanism is very difficult to understand. We need to do captopril test, suppression test before doing any PTCA or this kind of therapy.
See, in measuring the blood pressure, I think the cup size is also very important.
Yes, sir.
Yes, in our
Sir, rightly said, sir. Very good point. To measure our BP, actually, we measure BP in very hurry. In our hospital also, and we all know that we put the cuff, whether the patient size is big or small kid, we measure the BP with same cuff. There are a lot of reason behind this, but in case of resistant hypertension, you are right, sir. The measurement technique and measurement apparatus should be all right. It should cover 2/3 of the arm, and yeah, the cuff should be tied appropriately with at least one finger gap, and all these are required, sir. You are right, sir.
And among the newer drugs still is another drug, direct renin inhibitor, enagrelin.
Scarin, direct renin inhibitor. It is difficult to cover all the drugs in this simple talk because there are in the beginning I told that resistant hypertension is difficult to understand because of the non-uniformity of the prescription. There are lot of renin inhibitor, there are ACE inhibitor, ARB inhibitors, dual inhibitor, many things. It's difficult to cover, so I just limited my talk to important points only. Yes, sir. Herbal medicine also, sir. We take the history, but patient will not believe us if we tell them that it is the opposite of this. Herbal medicine, Ayurvedic medicines, because if they contains any heavy metal, they can damage kidney also. But it's difficult to convince the patient.
Sorry, sir. Thank you, sir. We can take the other questions. We have a separate question and answer panel discussion at the end of the first morning session. So if you have any other queries, you can have it in that time. Thank you. I would like to call upon the chairpersons to felicitate the speaker, please. Tari, sir. A big round of applause, please. And I would like to call Dr. Mrs. Ravi Khurana, ma'am, to felicitate the chairpersons, please. An active participation of the audience is a must, but I must just request the people at the back to keep a little less on the noise. A gentle reminder that there is a poster presentation that is started at 10 o'clock and it is going to be from 10 a.m. to 12 p.m. There are 9 participants for the poster presentation and we have a panel of 5 judges, Dr. K.C. Lohoni sir, Dr. P.C. Gloria sir, Dr. Pankaj Gupta sir, Dr. M.S. Bhatt sir and Dr. Nilambar Bhatt sir. So these are the judges on panel for the poster presentation which will be in the corridor and it will be from 10 a.m. to 12 p.m. Thank you. The next talk is by Dr. Rahul Gupta, sir, Director and Head, Neurosurgery, Fortis Hospital, Noida. Sir has more than 18 years of experience of neurosurgery, and he'll enlighten us on the glimpses of brain and spine surgery in clinical practice. The session would be chaired by Dr. Rahul Singh, sir, from Krishna Hospital, Dr. Nimesh Gupta, and Dr. Kapil Singhal, sir. Thank you.
I will request Dr. Rahul Gupta to please come on the dais and start his lecture.
Good morning. Thank you, IMA Uttarakhand, for giving me a chance to speak. Thank you, Dr. Raut Singh, who is a very dear friend, for giving me a chance to speak on this podium. I shall be taking you through the journey of brain and spine surgery, which we are doing at Fortis Hospital, Noida. This is almost around 75 to 80% of total neurosurgery work that is being done in all over India. The quality of the work is similar to that. And in India, we are doing almost everything in brain and spine surgery that is being done everywhere in this world. So this is something about me. I have got around 20 years of experience, and I did my MCH from PGI Chandigarh. So when we talk about brain and spine surgeon, initially we thought that we are just the neurosurgeon who are doing head trauma or brain tumors. But apart from that, we are doing vascular brain surgery, head injury, spinal disc surgery, spine fixations, endovascular neurosurgery, epilepsy surgery, endoscopic surgery, and functional neurosurgery, which involves deep brain stimulation for correction of Parkinson's. And what has helped us in recent years are the new gadgets and new safety measures which have made the surgery very safe. About 2 decades ago, we used to think about that the patient comes walking and goes back on four shoulders like the patient is not surviving anymore, but this is not there anymore. Now we have a success rate of more than 95% in most of our surgeries because of high-end microscopes, endoscopes, biplane modern cath labs, intraoperative CT and MRI, new neuroanesthesia techniques and equipment. I thank the neuroanesthetists who have given us the chance to perform well and do good quality surgery. Other machines, high-end machines like neuromonitoring, high-speed drills, CAM, neuronavigation cubes are also helped us. When we talk about brain tumors, we come across these terms: meningioma, glioma, pituitary tumor, and metastasis, of which meningioma, glioma, and pituitary are the primary tumors of the brain, and metastasis, as you know, is a tumor arising from any other part of the body. So this is a glioma MRI, which shows the glioma in that yellow circle, and this is what we see through a high-end operating microscope. So additional we have this dye. When we give this dye to the patient before surgery, then this tumor looks separate from the brain. It fluoresces, and this can be removed safely without touching the normal brain. And you can see the uh, the uh, the gift which the neurosurgeon gets is a post-operative CT scan where the total removal of the tumor has been performed. So this is the tumor fluorescence, which is intraoperative, real-time for malignant tumors, and we give this dye either orally or intravenously, very economical, and it is helpful in tricky cases. Then we also have the gadgets like doing an awake cannot be. We often see the patient is talking to us, singing, moving his limbs, or even playing the guitar. So, like for this example, where the tumor is located in the motor cortex, the tumor is located in the area of the brain which is important function of the limbs. In that case, we do all these special sequences of MRI like spectrography, functional MRI, keep the patient awake, fix the head, use neural navigation to decide about the location of anatomy, talk to the patient, and do the surgery. In the surgery also, because we are so precise, we do not cut the brain, but we go through the natural passages of the brain and remove the tumor. So this is the natural passage which we have opened up, and the tumor is removed. So this is how we check, and then we close the anatomy wound, and the patient is still awake, and there is no deficit. We have the facility of doing neuro monitoring also. For example, in this patient where the tumor is again located in the motor area, in the located area, we use neuro navigation, neuro monitoring. Again, the patient is awake. We remove the tumor, ask her to move the hands and legs during surgery, and post-operatively, the tumor has been removed. Patient has no deficits. We have these tumors, large tumors in the skull base, large meningiomas, acoustic tumors, which can again be safely removed with the new gadgets, new techniques, and good neuroanesthesia. So these are some examples of these large tumors which can be removed safely. Another 26-year-old lady who had come with problems of headache and vision problem. This is the large tumor. This white color tumor is large tumor. This tumor is so large, it is almost the size of a tennis ball. And this tumor was removed operatively. This is the tumor, and this is the patient on the second post-operative day. So these are the results, not just the survival, but the quality of life is also kept in mind nowadays while performing these surgeries. Brain tumor for a patient who is 3.5 years old child with headache and seizures. This is the large tumor which was removed again with the help of these gadgets like operating microscope and new anesthesia techniques. And this is after 4 days after surgery where the diagnosis BNET and patient underwent radiotherapy and went back to his country. Another patient came from Iraq with a large brain tumor. This is the tumor. This is after 4 days getting discharged. Some tumors are located very deep in the brain, difficult to access, difficult to operate, but we can operate sitting position. So this requires some special gadgets which we have to perform the surgery in sitting position. The patient is sitting and we are performing the surgery. We access the brain through the natural tumor passages, and this is how we access and successful. We have got endoscopes. We use endoscopes for third ventriculoscopy in cases of hydrocephalus, for skull-based tumors like pituitary tumors, and for inspection of the tumor cavity after removal of the tumor. And this is the example of a pituitary tumor, which through the endoscope, through the nose, we can go without any stitch, without any cut, we can remove the tumor. This is how the tumor is removed. So this is the patient on the first post-operative day. There is no cut. Patient is accepting orally. This is after 3 days, just before discharge. Sometimes the tumors are located in the suprasellar lesion, impairing the vision. In elderly patients, difficult to access. But here also we take a chance to remove the tumor, and you can see how the patient is happy. She came from Nigeria. She was suffering for almost 2 years. Everybody has given hope there, but she came to us, and we gave her hope, gave her life. Another patient with a very large tumor in the anterior skull base. So this tumor was also removed. The chenotomy, this is the last chenotomy which we have done in the frontal region. Quite cosmetic. This is the post-operative, and this is serially she had come over many years for up to 6 years. Another old lady with a tumor in the skull base, also in the temporal lobe. This tumor was again removed. This is the first post-operative day. Then after extubation, she is happy and she's smiling. She doesn't have a teeth, and this is at the time of follow-up removal. So we have neurocath lab where we, in these cases of tumor, we do tumor embolization. This is especially required for skull-based tumors like meningiomas, hemangiopericytomas, nasal angiofibromas, carotid body tumors. We can see the tumor, we can see the location of the vessels, and we can see the vascularity of the tumor, and we can do a pre-operative embolization. Like in this case of meningioma, you can see the circle, the tumor blush. The dye is going into the tumor, and there can be a lot of bleeding while doing the surgery. So we go and we embolize it, and when we embolize, we can see the vascular blush has gone. So surgery becomes simple, bloodless surgery. No blood loss, no blood transfusion. So it saves cost as well as saves the morbidity. Another patient with a large carotid body tumor in the neck. You can see a large tumor. She came from very far off Sierra Leone, that is in the West Africa, and this was the tumor. You can see how vascular this tumor could have been. So first we did a balloon test occlusion in the internal carotid artery so that if the artery is sacrificed during surgery, there should not be any stroke. We checked that, and then we went ahead with the tumor embolization. We embolized the tumor, and the surgery field was quite avascular. And with the help of oncology team, oncosurgery team, we did this, and this tumor was removed. And for the first post-operative, the patient is extubated in the ICU. She is conscious. Another precious patient, young child with a large right plexus papilloma in the ventricle. You can see how this tumor has been removed, and this is the patient who is happy after a few days at follow-up. Some happy patients, you can see these are for the brain tumor surgery. Coming to vascular neurosurgery, we can do aneurysm surgery like for subarachnoid hemorrhage. Whenever there is subarachnoid hemorrhage, we have to suspect an aneurysm. We have to do an angiography, and when we do the angiography, we see this aneurysm. On the left side in the circle, we can see a balloon-like structure arising from the vessel wall, which is aneurysm. We have got two options. One of the option is doing a clipping. We apply a clip through a high-end microscope. Through a high-end microscope, we can see that bleb like this within the circle, and we apply a clip on that. And then with the help of tumor, with the vascular fluorescence, we can check the adequacy of the clip, and we can see whether there is any blood flow within the aneurysm or not. So you can see beyond that clip, there is no blood flow, the aneurysm is not visible. So we have cured the disease. So in this aneurysm, we have cured. He will not have a recurrence at this site. Sometimes we have a hydrocephalus, we can go for either ETP, as I told, through endoscope, or we can put a shunt like BP shunt. Then we do surgery for epifacial spasm. We do surgery for facial pain, which is known as the trigeminal neuralgia or the suicide disease. So we do microvascular decompression. We go from behind the ear and we remove the vascular structure coming in contact with the seventh or the fifth nerve to cure these patients. Patients come to us with CSF leak through the nose. That is the CSF rhinorrhea. So that CSF rhinorrhea is done by us. We do a CT stenography, see the site of CSF coming out through the nose. We go ahead, put a dye, see the CSF coming out, and then we plug the hole with the help of fat or other tissue, and then cover it with Surgicel. Coming to spine. After the brain, we also do spine surgery called thoracic, lumbar, and sacrum spine. With the bad posture, the problem of spine disease is increasing gradually, and more patients are approaching orthopedic or neurosurgeons for their spine problems, and about 1% of them may require surgical intervention. So we do surgeries for spine pathologies like congenital diseases, trauma, tumor, degenerative diseases, autoimmune diseases, even vascular malformations, and non-specific like trauma, bad posture, osteoporosis, and smoking. Starting from the top, we have the craniovertebral junction where we see this odontoid process or the C2 vertebral body is compressing onto the spinal cord, and there is a pinching of the spinal cord and patient is having deficit in the form of quadriparesis. So we do a CT scan, X-ray and all these things, and then we operate, we open that space, decompress the spinal cord and do a fixation like this. We can do it with the help of wire, we can do it with the help of screws and rods. So this is the occipital cervical fixation which we can do. And sometimes patients who come with odontoid fracture, we can go from the front and put a screw known as the transodontoid screw. This is a patient who underwent this surgery and was discharged. Spine fixation can be done from front as well as from the behind for various types of cervical canal stenosis, like in this patient from anterior as well as posterior aspect. This is a patient who had a cervical disc at 2 levels in which we did a corpectomy and put a bone cage, bone graft, and then fixed it with plates and screws. Another patient with single level disc burn, we did the microdiscectomy with the help of microscope and put a cage, that's an implant to cover up that gap and fixed it. This is the implant, and you can see the scar is hardly visible. I can tell you in Haldwani and Rudipur, we have got 3 doctors who got operated for the similar problem by me, and they are doing well. Another patient, the scar is hardly visible. Some patients, they want an artificial disc so that they can preserve the motion at that level. That can also be performed, especially in young patients who do not have any osteophytes. Then we do the surgery for the tumors as well as tuberculosis of the cervical spine. This is a case of thoracic tuberculosis where we can see the body is collapsed and there is a tissue which is compressing the spinal cord. Patient has come with paraparesis. CT scan shows the destruction of the bone. We did the spine fixation at that level with the help of screws as well as cage. Another patient of tuberculosis at the level of lumbar spine. So again, we did the X-rays, MRI, and CT scan, and then fixed this with the help of screw rods after decompression of the neural structures. So the neural structure compression may lead to pain, may lead to deficits, and we have to reverse that by decompression. Then some patients they come with prolapse discs. This is a very common problem. But some patients who have significant prolapse discs, who have neurological deficits, severe pain, letter bowel involvement, in that case we may have to go for surgery. If the patient is young, thin, and not too much of damage, and it's a paracentral disc bulge, we only do a microdiscectomy with the help of endoscope or microscope through tubular filter and remove the disc like this. But sometimes if the patient is having a major problem, central disc bulge, multiple levels, old age, along with ligamentum hypertrophy, we may go for fixation. We have the option of this percutaneous fixation where we put these multiple ports through separate holes, join them, and we do not give a big incision. So this is how the post-operative wound after doing fixation at 2 or 3 levels looks like. Then we have body tumors. This patient who had come to us, young patient, 17 years old with a large tumor of the dorsal spine. So we did complete corpectomy, removed the tumor in the bone completely, and fixed it with the help of cage and rods, and complete excision of the tumor was done. Follow to 8 years, patient was doing absolutely fine, but then he developed metastasis. Another patient of 40 years old came from Kashmir with backache. There were no neurological deficits. X-ray showed destruction of D12 vertebrae. We did MRI. Again, in that there was destruction and fracture of the vertebrae with some cord compression. Though she did not have any neurological deficit, we operated upon her. We put cage and screws and rods, and this is what she was. Plasmacytoma was the diagnosis. She underwent radiotherapy as well. Another example of a patient of a young female who fell from bike in Sonipat, severe back pain with leg fracture. My classmate operated upon the leg and then referred the patient to us. There was a severe fracture of the sacrum and lumbar vertebrae. You can appreciate these fractures, multiple sacral fractures on both sides. We operated upon her. We did a lumbar relaxation, fixation of the sacrum as well. And this is how the X-ray looked like post-operatively. Patient had some pain for some time, though there was no significant visits. These are the follow-up scans, and patient was absolutely normal after 1 year and doing her normal activities, normal chores of the life. Then osteoporosis is very common for problem with aging population. This is how the osteoporosis present to us. The bone becomes thinned out, the bone becomes weak. So there is a chance of fracture. Vertebral fracture, compression fracture after trivial trauma, minor trauma is very common in osteoporotic or young patients. There we have a minimally invasive option of doing vertebroplasty or kyphoplasty. We can do it 1, 2, 3 or many levels at a time. For example, in this 103 years old lady who had come with D12 fracture, had severe pain, she was bedridden because of pain. We did kyphoplasty. We had put a balloon to raise the height and then put the cement. And this is this is immediately first post-op day, this is next day before discharge, and this is at follow-up. So these patients, they give you so much respect, they love you because you have made them stand on their feet. And these patients, these elderly patients want only one thing. They can go to the toilet for their daily needs. That is all. And if you can provide that, because passing motion or urine on bed is the worst thing you can have at this age. So making them ambulatory and walking again is the best thing, best gift you can give them. Then osteoporosis, sometimes we need to fix if there is a significant fracture. We cannot just put the cement or there is a cord or nerve compression. Then we fix them with the help of these cement augmented screws. So when we talk about spine cases, there are certain myths associated with it that spine surgery will lead to paralysis in 90%. Even I have so many doctors, colleagues who have spoken to me and said that after spine surgery, यार पैर तो नहीं चलते, हम surgery करवा लें क्या? So I must tell you, in patients who come walking, the chances of paralysis or paralysis is less than 2%. If the patient has a deficit pre-operative, then it can happen, but otherwise not. So we do spine fixation for instability and trauma. We do decompression and fixation for degenerative spine diseases, especially in elderly. We do surgery for all types of spine tumors, extradural, interdural, or intramedullary tumors, congenital anomalies, and for acute PIVT. Coming to another aspect of neurosurgery, which we do at our hospital, is endovascular cath lab, where we do coiling for aneurysms. You can see the aneurysm, which I had shown we had clipped with the help of a microscope. Here we are taking care of this aneurysm inside the cath lab, where we are taking the catheters inside the aneurysm and filling it with coils so that there is no blood flow inside the aneurysm so that it doesn't rupture again. So that is the main idea, not to let it rupture again by stopping the blood flow into that part which is abnormal, which is diseased, and which is thin-walled. So these are the coils which are put inside the aneurysm. We can do balloon assistance, we can do it with stent assistance, we can just put a flow diverter, that is a special type of stent, and we can also put certain devices inside the aneurysm which are known as intraluminal devices. Though they are expensive, but this is how we put it. Sometimes there is a carotid stenosis leading to chronic stroke, multiple strokes, then we can do a carotid stenting and open up the vessel. We also do surgery procedure for acute stroke. In acute stroke, we have to treat rapidly, safely, and effectively. We can have anterior circulation stroke, posterior circulation stroke, but in this case, the catch is patient should reach the hospital within 4.5 hours for IV thrombolysis, or if the patient wants to get a mechanical thrombectomy done, or that is possible only if the patient reaches quite early, at least about 6 to 8 hours, because beyond that, we are unable to do. Like, for example, this 35-year-old gentleman came with recent onset drowsiness, aphasia, hemiplegia, and he was late for IV thrombolysis, but he came within 5 hours. So we did take him the cath lab. We can see on this image, the circled area is the area of middle cerebral artery, which is blocked. Middle cerebral artery is not filling up. So we took this stent inside, removed the thrombus, and you can see how this middle cerebral artery area or the middle cerebral artery has been opened up. So this procedure can be done. You can see the comparison. There the vessel is not visible, there the vessel is opened up. So this can be done within 6 to 8 hours of the arrival. This was the patient pre-operatively, then on the first post-operative day, before discharge, he is moving all 4 limbs, and then at follow-up at 6 months, he is smart and he is looking good. So mechanical thrombectomy is a minimally invasive procedure done in a neurocath lab for large vessel occlusion. We take the stent inside the vessel, or we take a aspiration catheter and remove it. There is a window period. IV thrombolysis can be done within 4.5 hours, but mechanical thrombectomy can be done up to 4, up to 6, 8, or even sometimes 12 hours, depending on the amount of penumbra. Now, what is penumbra? Penumbra is basically that salvageable vein where the blood supply is deficient but not totally cut off. So if there is a large penumbra, this procedure can be done even late. So for posterior circulation, we can do this procedure almost up to 24 hours. So the another method which I was talking about was thromboaspiration, where we take a wide bore catheter into the vessel, we just catch hold of that clot and pull it out. Like for example, this 32-year male, he had no flow in the middle cerebral artery. Even the internal carotid artery was blocked, and the circulation was totally in disarray. So we took this respiration catheter along with the stent, opened up the internal carotid artery, and we can see these clots, they had come out. And now the internal carotid artery, you can see, has opened up, but the middle cerebral artery is still blocked. So the middle cerebral artery also needs to be opened up because the main supply to that area is through that only. And then we took the aspiration catheter again, pulled out the thrombus, and we opened the middle cerebral. So now you can see on that side that whole circulation of one side has been opened up. These are the thrombi which have been removed, and this is the patient who improved in the postoperative period. We do surgery for hypertensive bleed like this and remove these clots. Trauma, an example of a patient who had come fall from height, construction site, multiple rods were piercing through it. Simultaneously, my son also came with fracture humerus. My friends took care of my son, and I took care of him along with my team of cardiothoracic surgeons because this patient was losing blood and was dipping. And this is the rod which we had removed, and this is us 2 days after surgery. So these are some of the other happy patients who we had operated over the years. And in addition, we do congenital malformations like we see in this child who is 34 hours old. Only he came to, he was 18 hours old. We operated upon this patient when he was 34 years old for this spinal meningomyelocele which was leaking. There's another patient with cervical meningomyelocele. You can see this small child, about 1 month old, and this is how we operated upon him, and child is happy. So thank you for your attention and patient listening. This is our team at Fortis Hospital, Noida. Kapil Singhal, who is our neurologist, who we work together and take care of these patients. Especially in stroke cases, we always work together. Thank you very much.
Thank you, Dr. Rahul. I think you have touched all the aspects of neurosurgery, hardly anything left. And Dr. Kapil was telling me you started rebrain stimulation recently.
Yeah. So when we talk
Few
about
words about that.
So, movement disorders are quite common, and Parkinson's disease is a big problem. The Parkinson's disease can even affect young people. In Parkinson's disease, we have tremors, we have slowness of the activity, motion, movement, even speech is affected. So, overall, the quality of life becomes very bad. So, the initial treatment is medicines, but after 5, 10 years, or even 15 years of treatment, there is a decreased response to these medicines. What happens is, if you give less doses, the effect will not be there, and patient will have disease. And if you give little higher doses, there are side effects of those medicines. So the window period or that bracket in which that medicine is actually effective becomes very, and life becomes a hell. In that case, we have an option for almost like 10 years where we can implant an electrode inside the brain and stimulate with the help of a small battery which is placed in the anterior chest wall, and that stimulates that thalamus region where we want the subthalamic nuclei, and the Parkinson disease is almost cured till the time that machine is working, that battery is working. So the patient's quality of life is significantly improved. So that procedure can also be performed for selected group of patients of Parkinson's disease after evaluation by a neurologist. It requires a surgery which lasts for about 10 to 12 hours, where we implant that electrode in the brain as well as a battery in the chest wall. So the life of the battery is usually 5 years if it is a non-rechargeable one, and if it's a rechargeable battery, it can work almost for 12 to 15 years. So this is the surgery which we have started at our place, and we have done 2 patients in the last 3 months, and both the patients are doing very well.
Thank you, Dr. Rahul. We can take one question because we are running short of time. Any question from the audience?
So the cost of the procedure, the cost of the procedure is not so much, and the stay of the hospital is about 6 to 7 days. But with the non-rechargeable battery, it will cost somewhere around 15 to 16 lakhs. And rechargeable battery we have not put yet, but I think that will cost somewhere about 6 to 7 lakhs extra apart from that.
Thank you so much, sir, for an informative and interesting discussion. As sir said, almost everything in neurosurgery was covered. Thank you so much. I would call upon the chairpersons to felicitate sir, please. A big round of applause. Thank you. I would like to call upon stage Dr. Pankaj Gupta, sir, to felicitate the chairpersons. Thank you. The next topic of discussion. Before I announce the next topic, I would like to request Dr. K.C. Lohani, sir, Dr. P.C. Fuloria, sir, Dr. Pankaj Gupta, sir, and Dr. N.S. Bhatt, sir, to judge the poster presentation, please. The next topic of discussion is recurrent infections of the urinary tract, another common problem which is encountered by most of us. The speaker is Dr. Pranjal Gupta, Associate Consultant, Division of Urology, Transplant and Robotics, Medanta Hospital, Gurugram. I would like to call upon stage Dr. Adarsh Kumar, Dr. H.S. Bhandari, sir, and Dr. S.P. Singh, sir, to chair the session.
Good morning, sirs. At the outset, I would like to thank IMA Haldwani for accommodating me on a very short notice. Uh, I've prepared a short primer on infections of the urinary tract with a specific focus on recurrent UTIs. So just starting off with a case scenario, like for us urologists, you have a patient with an infected kidney obstructed with a ureteric stone, patient going into sepsis. General management protocol is follow the sepsis 6 bundle of care, like give oxygen, IV fluids, antibiotics, take blood culture, lactate, and monitor urine output, which is a time-selected bundle of care. Then an CT is essential whenever an obstructive uropathy is suspected. So you confirm ureteric stone, there is unilateral hydronephrosis, and there is a periureteric standing. What is the next step? It calls for a urinary diversion. It can be in the form of a nephrostomy or a degestin placement. So for us urologists, it's like always the debate which is better how to decompress the kidney. So how in long-term studies, there has been no difference between the two decompression options. The choice depends on the local resources available. In pregnancy, it leans towards nephrostomy, and if the patient conditions if the patient is so much morbid, a bedside intervention is required. Therefore, the mode of diversion will change. So starting off with the urinary tract infection. So in the recent articles in the Nature Journal, so there have been a concept of the human microbiome. So what they have projected is that when the baby is born is 100% human, but as the man grows older, it becomes 10% human and 90% microbial. Another concept of metabolome has come up where they have reported the alteration in the microbiota of the human body with respect to the morbid diseases like the obesity, inflammatory bowel disease, ulcerative colitis, insulin resistance syndromes, type 2 diabetes. So the microbiota change and they vary with person to person. Another, why have we been told that the urine is sterile? A study was done and they did some sequencing and they found that urine has its own microbiota. So moving ahead with the biomedical research, we come on to the most common pathogen causing UTI, that's E. coli. The modes of the pathogenesis because the adherence, motility, toxins, which impairs ureteric contraction and evades the immune system. We have the general diagnostic tools for suspected UTI. That's a urine dipstick, urine culture, blood culture. Imaging includes ultrasound, CT, MRI, and even a differential scan like a DMSA to identify some recent scars or anything. So I'll be just touching on the important parts of the practical aspects of the diagnosis. So in a urine dipstick, a nitrite positivity, which is a more specific test, has a more specificity of more than 90% because the gram negatives convert nitrate to nitrite, which is detected. And leukocyte esterase, because the neutrophils produce that enzyme, and it is a good sensitivity, 70 to 95%. Further, you can do some direct microscopy, identify and do the gram staining and urine culture. Then there are some practical considerations for sending the urine culture. For the patients, 100 ml of urine midstream sample if UTI is suspected, and if erythritis is suspected, it should be a first void. In men circumcised, no preparation is needed. For uncircumcised, one should, this should be told to the patient, which is very important before they get the sample. So they have to retract the foreskin, wash the glands with soap. For women, they have to retract labia, clean labia with soap, and then give the sample because unnecessarily you will find a commensal or a surrounding colonization. And for labs, you have to culture within a few hours, not feasible, refrigerate for 24 hours, gram staining. So these are the thresholds now. Okay. So for acute uncomplicated female cystitis, it stands for 3. For acute uncomplicated female pyelonephritis, it stands for 4. For catheter-related, it stands for 4. Men with UTI, it stands for 4. And complicated and for asymptomatic bacteria and pregnancy, which I'll be covering in next slide, stands for 5. So, but the clinical picture is very important because in almost 25% complicated infections, the culture is clear. And if you are suspecting an upper tract obstruction, it might not be detected in midstream urine because that's the lower tract. So you might have to do a PCN culture, you do a nephrostomy, take out the urine and culture it specifically from the pelvic system. We see a lot of patients coming, especially females, coming with bacteria, and they are so much worried. But the general guidelines say we do not treat or screen asymptomatic bacteria in the following conditions, like women without risk factors, patients with well-regulated diabetes, postmenopausal women, elderly institutionalized patients, patients with dysfunction or reconstructed lower renal tracts, patients with renal transplants also, prior to arthroplasty surgeries, and patients with recurrent UTI. You do not need to treat asymptomatic bacteria. Two indications are there. We should address asymptomatic bacteria are one prior to urological procedures, which will be reaching the mucosa probably, and in pregnant patients. So coming on to recurrent urinary tract infections. So they are defined as more than or equal to 2 infections in last 6 months, UTIs, or more than or 3 in 12 months. It can be in any part of the tract. If recurrent upper tract infections, one must definitely look into the complicating factors. The severity can vary from a cystitis to pyelonephritis to urosepsis, and recurrent cystitis and some infections can be even more severe depending on patient. And then we come, why women? Okay. So the epidemiology says half of all women will have a UTI in their lifetime. Nearly 20% of women who have one UTI will have another. 30% of those will have yet another. That's recurrent. And 80% of those, 2.4% of women will have very frequent UTI. So for ladies, these are the risk factors depending on the age. Young and premenopausal women, it's all sexual intercourse, use of spermicides, new sexual partner, mother with a history of UTI during childhood, blood group antigen security status. For postmenopausal and elderly ladies, it's history of UTI before menopause, urinary incontinence, atrophic vaginitis, which is very commonly found, cystoceles, increased residue, urine catheterization, and functional status deterioration in elderly institutionalized women. Now, why they recur? Because there are bacterial gut flora, colonize the vagina, they enter into through the urethral matrix into the bladder, cause reinfection. The female urethra is short and broad, 4 centimeters and wider. There is external source, colonization of bladder. There is bacterial persistence within bladder, which can all cause recurrent UTI. So, investigations just touching up routine ultrasound. So there are some key points and basic checks in recurrent UTI as clinicians when we are seeing patients we should have in our mind. So always confirm with culture to label the patient as recurrent UTI. Ensure samples are provided and processed appropriately. Distinguish between culture positive episodes and culture negative symptoms. Ensure samples are provided when patient was not using antibiotics, can be a false negative. and don't routinely offer extensive investigations. You also need to take in proper antibiotic history because these patients will be rolling on so many antibiotics and then ultimately land into multi-drug resistance. Further, the approach, history, some points, severity of current episodes, severity of previous episodes should be documented. The antibiotic history, as I already told, is very important. The age-specific risk factors, the fluid intake, other urological conditions, medications, comorbidities, and if there is an acute episode, just follow, check the severity, and one should identify underlying anatomical and functional factors for a perineal examination. There could be a cystocele or a vaginal atrophic vaginitis, which might require addressing. Then investigations routinely midstream urine and a culture. Ultrasound is routinely recommended. Further investigations are not routinely recommended, but if there are some red flag symptoms, there are relapsing infection, there is suspicion, history of stone, history of multi-drug intervention, or there are some multi-drug pathogens. So broadly, the management strategies for recurrent UTIs revolves around fluid intake, behavioral modifications, non-antibiotic options, and antibiotic options. Now we start with fluid intake first. We combine it with behavioral modification. We combine then it with non-antibiotic options, and then we go to the antibiotic options, and which I'll discuss in further slides. The various non-antibiotic options like you increase the fluid intake, topical estrogens, use of D-mannose, cranberry is widely used. Methenamine hydrochloride has been found in the latest study in the ALTER trial. Some immunoactive prophylaxis, endovesical installations, and probiotics. So the date, what shall we do? So here are some of the recommendations. So if the patient is consuming less than 1.2 liter of fluid a day, if yes, increase it. Give topical estrogen if postmenopausal and signs of vagina. D-mannose and cranberry have good. Some patients can work. D-mannose is still, going in a prospective registry. And methenamine, there has been a recent non-inferiority trial called the ALTER study, which has proven non-inferiority of methenamine with antibiotic. So it can be considered as a probable non-antibiotic option for treatment of recurrent UTI. And probiotics, they are unlikely to be harmful. So this is very thin. I know the font size is very small, so I'll just zoom it in. Then we come to the antibiotic strategies. There are continuous low dose, which can be considered with behavior plus non-antibiotic. The mechanism is to eliminate the vaginal and introital flora. The harm is they will have eventually emergence of antimicrobial resistance. There will be an alteration of microbiome diversity. The protocols we follow for antibiotic prophylaxis are 3 to 6 months, low dose. So the drugs are trimethoprim, cephalexin, nitrofurantoin, and fluoroquinolones should be avoided, particularly here also. There is a huge resistance among fluoroquinolones. Breakthrough infections can be treated with treatment dose. Important point is use continuous or post-coital antimicrobial prophylaxis to prevent recurrent UTI when non-antimicrobial interventions have failed, and counsel patients always regarding the possible side effects. So this the whole spectrum revolves around this: cystitis, pyelonephritis, recurrent UTI, associated UTI in men, and urosepsis. So I'll just be focusing on recurrent UTI. Just few points about complicated UTI. Any UTI in a male is a complicated UTI. Then further other factors are obstruction, foreign body, reflux is there, recent history of instrumentation, healthcare associated, or isolation of multi-drug resistant pathogens, or in patients with having diabetes or pregnant patients. So the recommendation says for an uncomplicated cystitis, just prescribe fosfomycin or a pifcedimanan or a nitrofurantoin as first-line treatment for uncomplicated cystitis in women. Do not use aminopenicillins or fluoroquinolones. These are the suggested regimens for antimicrobial therapy. However, it will vary on to the antimicrobiome of the specific region. This is a brief slide, covering all the upper tract infections. Some key points regarding acute pyelonephritis. One should identify associated obstruction, systemically unwell. CT is important if complicated. Pyelonephrosis should be drained, no question. There should be high index of suspicion, and some patients can be very silent. They can be swinging pyrexia, night sweats, loin pain. Perinephric and renal abscess, use CT if more than 5 centimeter, drain, and if less than 5 centimeter, antibiotics. If symptoms don't resolve, we can drain. Then there is another entity, xanthocalamitis pyelonephritis, caused commonly by E. coli proteus, and it is a pretender of tuberculosis, and then RCC. So management has to be individualized. Another emergency condition is emphysematous pyelonephritis, where gas moves in the collecting system or in the parenchyma. There's a separate grading for it. It has to be dealt with percutaneous drainage, or an emergency nephrectomy will be required and has to be treated very soon. So just finishing off with some points on antibiotic prophylaxis, it's a short using single dose administration of an antibiotic substance in normal doses prior to start of operation. More is required as the patient has a greater ASA grading. It is a lower threshold for using prophylaxis. So recommendation is for ureteroscopy, percutaneous PCNL, TURPs, and transurethral resection of bladder, and also for prostate biopsies. For urodynamics, office cystoscopies, and we don't require prophylaxis. Just in the selection of antibiotics, consider patients have received antibiotics. Don't give the same antibiotic if the patient gets fever. You have to change the antibiotic. Stewardship is to prevent antimicrobial resistance, reduce harm. So just the take-home messages, UT symptoms and complications need to be individualized onto the patient. But the important fact is that it is a driver of antibiotic resistance in the community, and we should also having a knowledge about alternative strategies to antibiotic treatment in benign UTI. Thank you. Thank you for further, I would just like to highlight some of the services we are practicing in Vedanta also. Like we offer all kinds of urological services, including robotic urology, robotic transplant, open transplant, endourology, collab, everything. So the whole spectrum just I wanted to speak of. Thank you for this.
Hello. Uh, uh, Dr. Pranjal has covered all the aspects of UTI, I think, which is very much helpful for the general physicians and gynecologists as well as for the general practices. If there is any questions from the audience, we are open for some questions.
Sir.
Can you highlight the points regarding the relationship in recurrent UTI, relationship recurrent UTI and vesicular reflex in pediatric patient, and ultimately CKD as sequelae in pediatric patient?
Sir, could you please repeat? I could not hear.
Relationship in recurrent UTI and vesicular reflex (VUR)
Yeah,
in
VUR.
pediatric patient, and especially leading to chronic kidney diseases as
Yes, sir.
sequelae in pediatric patient.
So VUR is like itself as a risk factor, and in
So
pediatric patients.
when to suspect VUR in a
Yeah.
normal pediatric patient, we can't do every invasive procedure in a pediatric patient. How are then?
So, if the patient is having recurrent UTIs or a breakthrough infection, so if it has not been diagnosed priorly, we can continue on a low dose prophylaxis. But if patient has recurrent UTIs, a VUR is suspected, we go ahead with a VCUG, and then if there is any there is a grading of VUR 1, 2, 3, 4, 5. So accordingly, we treat, and there are guidelines to give low dose prophylaxis, continuous antibiotic prophylaxis, or treat the VUR, or if it is causing like we do differential renograms like DMSA and all. If we find new scars, there are scar progression which may affect the renal function in the as the child grows, then one might consider intervention accordingly. So if recurrent breakthrough UTIs and all are coming and there is a increase in cortical scarring, we might have to go ahead with a reimplant or plan a surgical procedure. Thank you. Thank you.
Thank you, sir. I would like the chairpersons to felicitate the speaker, please. I would like to call upon stage Dr. RJK Singh, sir, to felicitate the chairpersons, please. Big round of applause for the chairpersons and the speakers, please. Thank you. It gives me pleasure to welcome our next distinguished guest. He needs no introduction. Dr. Praveen Chandra sir is a leading Indian cardiologist and chairman of interventional cardiologists at Vedanta Medicity, Gurugram, India. Sir is going to enlighten us on the life-changing therapies in interventional cardiology in the year 2023. I would like to call upon stage Dr. Prakash Pant sir, Dr. Rashmi Xavier ma'am, and Dr. Bhuvan Chandra Joshi sir to chair the session, please. Thank you, sir.
Hello. We are very much thankful that Dr. Praveen Chandra sir, who is a Padma Shri recipient from the government of India, is with us. I welcome Dr. Chandra sir. He did not need any introduction. Already introduction inside of this. He is graduate, postgraduate, and specialized in DM cardiology from the prestigious KG Medical Institute, Lucknow. He already remained director in cardiology from Escorts Hospital, then Max Hospital, and presently he is the chairman in cardiology in Medanta Hospital. Sir is recipient of so many fellowship from the Asian Pacific Cardiology, European Cardiology, American Cardiology. He is the pioneer of the first trans-aortic valve implantation. He is the recently he did first tricuspid valve implantation throughout Asia. He is doing several angioplasty, complex angioplasty, and pioneer in the cardiology in the all India. Now I session to you, sir.
Thank you, Prakash, and it's a pleasure to be here this morning. Good morning to all of you. And may I request, I will be very brief. I'll finish the talk in 10 minutes, hopefully. So I will request a little bit silence in the room because otherwise it is no point. So all those people who want to talk a little bit more can be, go out of the doors on either sides. They are open. And please be silent. It will be very nice of you. So I'm coming to Haldwani after maybe 20 years. And 20 years back, I did a CME. I think when Prakash had just started his cardiology practice, something, that time. And that after that, I see so much development in the city and so many doctors also. That was our IMA program also in a small hotel. And this time we see so many people here. And of course, it is very heartening to see that in super specialists are also available in Haldwani. And nice hospitals like Krishna Hospital I see here, and all these hospitals have come up with such nice facilities. So we have also to move a little forward because what we were doing 20 years back is already being done here. So we have to move there also. And so I'm going to share with you where we have gone to. What can we do these days? So these are some pictures you can see here. And these are basically some devices which has been developed to treat various kind of cardiac situations. And I understand that many of you are not cardiologists here, so I'll try to make it simple and understandable. And of course, why we are talking so much about heart problems, because still today, worldwide and in India, the biggest killer of mankind is heart disease, even more than anything. Because and you see every day some young person dying somewhere, some doctors getting affected, and so on and so forth. And it doesn't give time. It is not like a fracture. If it doesn't heal properly, you'll still be able to move. If the heart doesn't heal properly, you are really in a bad situation. So this is one of the most devastating diseases which can affect people. So that is why we have to be careful, and we have moved a lot. And from 1960, when the first Birmingham heart study, so many of you who must have studied the textbooks of cardiology or medicine, the very iconic Framingham heart study was discussed. At that time, there was nothing, only some medicines. And when I was training, like in MBBS, Rajendra is here with me. He is my batchmate. Dr. Indu is my batchmate. We are here. The only thing which was available was Lasix, Lanoxin, and Potclor as the treatment strategies for cardiac patients. But now we have moved a lot, and we have moved from the heart even to the whole vessels. So a cardiologist has now become more like a cardiovascular specialist. Means the heart and the vessels of the body can now be treated for various indications, which I will tell you. So the first, I will tell you what is the new terminology which has come up. You must have heard of, cardiology, then interventional cardiology, and now it is structural heart cardiology, structural intervention. What is structure? The valves of the heart. So up till now, the only treatment for the valve was either medicines or surgery. But now we can replace valves of the heart without surgery. And this is known as structural heart interventions. So we can replace the mitral valve, the aortic valve, the tricuspid valve. As Prakash already mentioned, we did one of the first ones in Asia recently. Then the pulmonary valves also we can replace, and we can also now close the left atrial appendage. And as you may be remembering from the anatomy textbooks, that LA appendage, left atrial appendage, is a vestigial organ. And it was always told that vestigial organs do not have any function to play, but they have dysfunction to play in our body. And the commonest cause of stroke today is clot coming out of the left atrial appendage. So it is a harmful thing, as it was the appendix, which was the commonest surgery at one time. Still, I think, still common surgery. But LA appendage is something which has been realized that it is a dangerous thing at times, and we have to close it. So how do we close it without surgery? I'll show you in a brief while. So these are the procedures which are done for all these structures of the heart, and we can replace. And the name of these procedures you might have to know now, because up till every time there is some new name comes up. So the TAVI is transcatheter aortic valve replacement. TMVR we do, which is transcatheter mitral valve replacement. The transcatheter tricuspid valve replacement. LAA is left atrial appendage occlusion, where we stop the appendage, we close it. And then tibial closure is paravalvular leak closures, and mitra clip is for treatment of mitral regurgitation or mitral leakage. So now let me go quickly, very briefly, because aortic valve, you may be remembering that the main valve of the heart is the aortic valve, which is the main gate of the ventricle. And when it becomes narrow like this, you see, it is normal, it is like this. When it becomes narrow, it doesn't open well, and then patients develop a lot of symptoms. And then the treatment was only surgery. And surgery cannot be done to everybody, as you understand. Some patients are weak, some are old, lung problems, etc. So the trends are changing now. Lot of patients are now getting valve replaced without surgery. And this treatment is known as TAVR. So the number of TAVRs have gone more than surgical replacements. These are the valves, this is how it looks like. These are the valves which we use without surgery. So we do a echocardiography test, diagnose these patients, do a CT scan, make a plan, and then do the implantation. So this is how it is done. That we go from the femoral artery. It is done under local anesthesia, as was being said by one of my neurosurgical colleagues in surgery. But here you see that we do everything under local anesthesia. There is no GA, there is no cut, there is no stitch, and we replace the valve like this. This is the animation which you can see, that this valve is first dilated, make a passage there, and once the passage is done, then we replace the valve by this catheter, which is holding the valve inside. And once we are in exact position, we release the valve inside. You see how it is released? And there is no stitch at all. And we keep checking under fluoroscopic examination. And this is known as the cardiac cath lab. So this is the valve replacement without surgery. And generally, the patients are discharged in 2 to 3 days' time. There is no recovery time and no morbidity or mortality is generally seen in these kind of situations. So how do the patients look? So this is a surgical patient one day after surgery, and this is how they look after TAVR procedure. Day 1, and generally they are discharged in 2 to 3 days' time. And this is how we do this. You see, This is a real patient where the valve is being deployed and the patient's heart is moving. We are deploying the valve, and once the valve is in position, it stays like this. So this is a new valve inside a diseased state. Sometimes we even replace two valves at the same time, double valve replacement. In this patient, we have replaced two valves, mitral and aortic together. So this is also advancing a lot quite rapidly, and for all kind of patients, elderly patients, 80 years, 90 years, and yesterday only there was a patient from Haldwani I saw, 99 years old, who is being planned for a valve replacement. So you can imagine that how easy it is to treat these patients without doing any surgery, and they can take these procedures quite well. And even younger patients, like this patient was 165 kilo. He was rejected by surgery from all the surgeons in Delhi. So he came to us and we replaced the valve without surgery. It is transcatheter valve replacement. And this is how they come back to normal life very quickly. And these are the patients where you can see that this aortic valve TAVI treatment has become very, very effective, very powerful therapy in patients with severe aortic stenosis. Then TMVR is a replacement of the mitral valve. You can see that the mitral valve is being replaced. And again, this is done with the help of cath lab and transesophageal echo, where it is done to see how it looks. And this is the patient. So all these patients are elderly patients, where nothing is possible, and you can do this. And we did one of the first ones many years back. That was the photo of that patient. What is left atrial appendage occlusion? It is an alternative therapy for oral anticoagulation to reduce risk of stroke in atrial fibrillation. So up till now, atrial fibrillation was a very usual arrhythmia, and any physician or any cardiologist would say, I don't worry too much about it. But now we have realized that all those strokes which were happening were actually because of AF. And it appears very, is very, very non-critical or non-serious problem, but left atrial appendage is where in patients of atrial fibrillation, the problem happens. And why this happens, you can see here. This is a left atrial appendage where a clot is jumping inside. This is a real life patient. And this clot will one day suddenly jump out and go into the brain. So if we don't block this, then this clot will go and create a stroke. And stroke is one of the most devastating complications of, neurology. And of course, then there is no treatment. So basically, we have to prevent stroke, and this is how we do it. We put a small umbrella inside. This procedure takes about, 45 minutes, and this is many patients where we do it. This is a patient where we replace the valve transcatheter, and then we are doing this is the device which is being put and in the cath lab, and then these patients are discharged the very next day. So any patient with chronic atrial fibrillation, high risk of stroke, and is not able to take medicines or is not tolerating medicines should be given this therapy known as LAV. Then mitral regurgitation is another problem of the mitral valve, where the valve is leaking, and the only treatment for these patients is surgery. Now we can put this clip. So this clip again goes through the femoral vein, and we take it inside the heart, and it takes about 45 minutes for us to do this, and patients can be discharged the very next day. So this is how the clip looks. You see, this is the clip. This patient already has a pacemaker and is now getting a clip because he has got a severe leakage of the mitral valve. And sometimes we've got one clip, sometimes we've got two clips, and this is quite a easy procedure, although expensive. And these patients do not need to take any anticoagulation. No anticoagulation is required. They just remain normally. Then tricuspid valves also now we can treat, because these tricuspid valve regurgitation patients, and recently we treated one patient where we did the clip. He was waiting for a transplant, liver transplant, and he was not taken for surgery, but when we did the clip, after 15 days, surgery was done for the liver. So these are options for tric valve and tricuspid clip. As you can see here, this is the valves which are put on both sides of the SVC, which is superior vena cava and inferior vena cava. And this is one of the patients. You can see that he underwent no surgery here, and this is the clip which is done, and the next day the patient is being discharged. Then we replace the valve sometimes by, again, in those patients where the valve is leaking, and also In previous open heart surgery patients where the valve has been replaced and they start leaking again after 10 years, 15 years. Nowadays, we don't need to do second surgery. You do a clip, just a small plug over there, and they can stop the leak. So this is how it looks. So this is all a little brief about the structural or valvular heart interventions. A lot can be done these days, and certainly the results are quite, reproducible, quite effective, and in reducing symptoms, and of course prolonging life. Then in coronary procedures also, a lot of procedures are being done here, and in Rudrapur also, Dr. Rashmi is sitting here, very, very active. And of course, but still there are many patients who are much more complicated, much more complex, multi-vessel disease, very weak hearts, and low blood pressure, hypotension. There we need some more intervention, more precision, and then we use more technology there, like fractional flow reserve, intravascular ultrasound, OCT, which is optimal coherence tomography, and shock wave and drilling and all sorts of things. And of course, sometimes patients are very sick, then we put them on, like IBP is available here, I'm sure. But now we even have this Impella system where we can put a pump inside the heart while we are doing the intervention. So this is the Impella pump. You can see this Impella pump stays inside, and we can then do the intervention. Patient stays stable, and then of course we can remove it. So that is the Impella. And as I said, we can look inside the arteries by intravascular ultrasound. And in many patients where there are previous problem, bypass surgery done, multiple blockages like this patient was very sick. And then, he was having bypass surgery in the past. The grafts are failing now. So we did his angioplasty with Impella insertion and shock waves. This is the shock wave. This is also known as intravascular lithotripsy. The same method which is done for nephrolithotripsy, the stones of the kidneys, we do it for the heart vessels inside, because sometimes the blockages are very hard, calcified. So we do these shocks inside, and patients can hear this voice of shocks in their head when we give the shock. And after that, then of course we sometimes put a stent, sometimes we don't put a stent these days, and vein grafts are also treated, and then they are discharged in 2 days' time. So that is the benefit of doing these intervention, and this is what we call as protected PCI, protected percutaneous coronary intervention or angioplasty. So those patients who are sicker, those patients who are more complex, they need protection during intervention. And this is known as protected PCI. And also we do use a lot of laser details. And through the laser, we vaporize those blocks, the thrombus inside. This is how the laser machine looks like. And this is excimer laser, which we use. And this is how the laser comes out from the catheter at the tip, and it keeps burning the tissue as you go inside. So this is the, as it, photo ablates, you can see the laser is going inside and trying to ablate the plaque inside. So debulking the plaque, and many times we don't even put a stent these days. So for 30% times, we do not put stents inside now, because stents still have their own problems, and this patient underwent a laser and balloon and no stents inside. So, and we check it with IVUS, we check it with OCT to see whether the result is good or not, and be sure that yes, everything is fine. So, but all this has to be done with all this technology. And another technology which we use, the hybrid cath lab, which is like a robotic cath lab. As you can see, it moves in 360 degrees direction and has the capability of surgery being done on the same table sometimes, if required. So, so all kind of complex cases can be done here, which is what we do in our structural heart and complex cases. So you can now see that we have really moved on a lot, and a lot of patients are coming from various to get cheap. The most problematic is the cost of the materials here in India. The doctors are still very cheap. As all sitting here, we know exactly the story, which is very expensive in Europe and America. And the last is I'm showing you a leadless pacemaker like a capsule. And this is a pacemaker which was done earlier. And now you can see this is the type of pacemaker which we used to do with the incision. Now there is no incision. These are capsule pacemakers without the lead, as you will see here. That this is the capsule which goes inside the heart, and it just stays inside with a small
monitor device is traditionally connected to the
There is a
heart by
small
wire.
tentacle through which it stays
There
inside.
is
This is
now
the
a new
tentacle.
pacemaker
It's a
option
small size, 1 gram,
that is the world's
and it works for 10 to 12 years. So this is the kind of technology which we have come to. So to conclude, my dear friends, we have come a long way. I don't say we have to stop here. It will keep moving, and we don't know which direction we are going to take, but certainly for good. And we have moved from CCU care, from bypass surgeries, from drug-eluting stents, to multi-vessel angioplasty, to high-risk angioplasty, to structural heart disease like valvular interventions, and of course, we also do the closure of the holes like ESD, VSD, PD, everything. So with this, I will stop here. But let me tell you at the end, I must also again say that technology is there to help us. Technology is there to treat, but we have to still take the history of the patient and also touch the patient unless until they will not get satisfied. So the satisfaction comes from the empathy, the sympathy, and the compassion, which we still have to mix with our intervention, and otherwise it doesn't work anymore. Thank you very much, and hope to see you some other time.
Thank you so much, sir, for enlightening us with all the journey of the cardiology. Because we, all the medicos in hall, we started our cardiology with the 4D, digitalis, diuretics, digoxin, and dilators. And later on, we keep on growing with this technology. As sir already said previously, this simple angioplasty, then complex angioplasty. Now angioplasty is done under the supervision of the intravascular ultrasound, intravascular lithotripsy, or this is called precision angioplasty. And beside this, then we went into this of structural intervention. So, lot of our population is now aging population due to the advent of medical facility. So, most of the person we also face the aortic stenosis, is mitral stenosis, MR. So, in such cases, previously they are denied of any medical therapy because they did not face they are due to complication of this high risk of the cardiovascular surgery. But now the advent of the structural intervention, there is a pioneer in India and Asia regarding these aortic valve replacement, tricuspid valve replacement, mitral valve replacement by percutaneous way without any open heart surgery. So now this is a advances of the cardiology, advances in the science, advances in the biotechnology, and we are now in this position that we can tackle all these therapy in a very non-invasive manner. Sir. This is the service of science to the our mankind. Now I congratulate sir for being us in this lecture hall, and thank you, sir.
Thank you. If there is any question from anybody here, anybody have?
Yes, I have a question, and that is about therapy. We have the normal route of basically doing the procedure via femoral route. In your experience, in patients who have severe peripheral vascular disease, what are the other alternative routes, and what is your experience on that?
Yeah. So sometimes patients have vascular disease like femoral arteries disease. So then we go from the subclavian artery or from the carotid artery. And even sometimes carotid artery and subclavian is also diseased. Then we go from the femoral vein through the inferior vena cava. We puncture the aorta, IVC to aorta, and then aorta to the implantation. So many approaches are available, and we can do that. And this IVC approach is also looks very dangerous, but it's quite easy to do.
Any questions from audience?
Thank you. Thank you very much.
Leadless pacemakers and hybrid cath labs. Thank you, sir, for updating us regarding this ever-changing and dynamic branch of cardiology. I would like to call upon stage Dr. J.S. Khurana, sir, to felicitate the speaker and the chairpersons as well. Thank you. Sir. Rashmi ma'am, please. A bigger round of applause from the audience, please. The next talk is on laparoscopic surgery for gastrointestinal and hematopancreatobiliary cancers. The speaker is Dr. Vivek Mangla, Director, GI and Hepatopancreatic Biliary Surgical Oncology, Max Super Speciality Hospital, Vaishali. The session will be chaired by Dr. L.M. Upreti sir, Dr. Sanjay Joyal sir, and Dr. Amar Pal sir.
Good morning, everyone. Thanks for the kind introduction. It's always a pleasure to be in Haldwani. Myself, Dr. Vivek Mangla. I do an OPD in Haldwani every month, and I come here 4 Thursdays. And I've met a lot of people in the audience, Dr. Jual, Dr. Amarpal, Dr. Preti, and quite many of you sitting in the audience as well. So today I am kind of going to talk about how, just continuing from where Dr. Praveen. First of all, in the presentation, I'll be outlining the benefits, why we are moving towards minimal access, and then I'll be showing you some surgical videos, just trying to highlight that how and why cancer surgeries can be done with these techniques and how they benefit the patients as well. A brief about Max Hospital Vaishali. Max Hospital Vaishali has a dedicated cancer center. We are known by the Max Institute of Cancer Care, and we have a very unique model by which we work, and that's probably one of the reasons we are able to do this quality work. We have disease management groups, and that's what the world over the world is moving towards. We as medicos really understand that when we talk about any medicine, it used to be general medicine, that when we talk about any medicine, it used to be general medicine. And then people venturing into cardiology, gastroenterology, nephrology to do all that super specialty work. The same thing is happening in oncology nowadays, especially on the surgical side, wherein it has been very clearly understood that people who dedicatedly work in a subspecialty of surgical oncology, for example, we have head and neck oncology, we have breast oncology, we have gynae oncology. So there are people doing specific subset of work in the entire surgical oncology spectrum, because that is what helps achieve excellence and trying to kind of get the latest advances which are known worldwide and get them implemented in the guidelines, get them incorporated in the treatment plans for patients, thereby helping us get very good outcomes. Coming to something which is close to my heart, minimally invasive surgery. So when we talk of laparoscopic surgery or minimal access surgery, things started in way back in late 80s and 90s when people started doing laparoscopic cholecystectomies. At that point in time, there were lots of questions asked. Why laparoscopy? It has a potential to harm, takes longer. But then finally, as we stand today, laparoscopic cholecystectomy has become the gold standard way of treating patients with gallbladder stone disease. And I'm pretty sure we'll have a consensus from the entire house on this. Subsequently, more procedures, appendicectomy, hysterectomies, then going on to hernia surgery. And now, over a period of last 20 years, there has been a significant progress in people developing skills for doing these cancer surgeries the way the cancer surgery is supposed to be done. It's not that you do it laparoscopically, so you're cutting some corners. You have to do the surgery inside the same way. But the patients benefit the same way as a patient who undergoes a laparoscopic cholecystectomy compared to a patient in today's times who undergoes an open cholecystectomy. We know there is lesser pain. The patients walk home earlier. There is much faster recovery. And with faster recoveries, we see that the patient is able to get to work much faster, you get better cosmesis. The blood loss also tends to be less. One advantage of doing laparoscopy is that the moment you have blood loss, you lose vision. And that is why somebody who does laparoscopic surgery is very, very careful about blood loss. So you end up having much less blood loss than open surgery. The wound is not there. And obviously, once you do not have those big incisions, you do not have wound infections, and you have much lesser hernia rates as well. Coming down to the biggest challenge which has been in convincing people about the benefits of laparoscopy in oncosurgery has been the oncological outcomes. And I can assure you that there is plenty of literature now very clearly showing that for abdominal malignancies, be it gynae malignancies, be it urologic malignancies, be it gastrointestinal malignancies, laparoscopy has established itself as gold standards in some places and at least as good as, if not better than, open surgery in most others. Coming down to, yes, I would not better than open surgery in most others. Coming down to, yes, I would accept there is a limitation. There will be some situations, very complex cases that we do, and I'm going to show you some examples of that, wherein it would be really difficult to do them, or the operating time would be so long that the patient wouldn't really benefit. So this is a school teacher from Noida who actually underwent an Applebee's procedure. The name sounds fantastic. What we're trying to talk about here is a patient who's having pancreatic body tumor with involvement of the celiac trunk, which supplies blood to the entire upper abdomen. And we now have surgical techniques wherein we can use our knowledge of anatomy to remove these tumors along with the celiac axis and then achieve good outcomes. So seemingly something which was considered inoperable some time back, with good knowledge of anatomy, good use of neoadjuvant treatment, can become operable. So if you have a pancreatic body tumor, which somebody says there is vascular involvement, then quite likely that this will still be operable and resectable. So it is important for the patient to reach such a place. This was another interesting lady who shows that if there is a will, the patient has to be willing to go that extra path. The treating team has to be willing to be along the patient. So this was an 18-year-old young girl who presented to us with a CA colon and bilateral adnexal masses. She had huge masses. This lady had been going around for good 18 months before being treated with ATT, everything. And then she underwent something which we call a cytoreductive surgery and HIPEC. This is a major surgery, covers all quadrants of the abdomen. And therefore, obviously, this has to be done by open technique, again, with good outcomes. Major liver resections also tend to be, you can see a spectrum of diseases having been treated here. And that can also be done. That is also usually done by open technique. Similarly, major tumors involving the major. So this was a very interesting patient, had a large retroperitoneal tumor, and there was a complete IVC involvement, if you can see there. And then this patient had a resection of the tumor along with replacement of the IVC with a cable graft with reimplantation of the left renal vein into it. So seemingly inoperable tumors, seemingly very nasty looking diseases, can also be treated very well, but then sometimes they would need open surgery. Similarly to recurrent retroperitoneal liposarcoma, so this surgery was patient's fourth surgery for a recurrent liposarcoma and needed extensive resection, but yes, these can be done and patients benefit from them. Coming to the topic for today, minimally invasive or minimal access GI HPV surgery. So I'm going to take you through 4 of our surgical videos and then showing some pictures of patients post-operative recovery. And I'm pretty sure lots of you would have seen patients in your earlier times who have undergone open surgery or still be seeing, and you'll be able to see the difference in recovery as well. So this was esophagectomy, once considered a very formidable operation, neck, chest, abdomen, all three can be now done laparoscopically very well. So this is a video wherein the abdominal part is being done first. That's the Ivor-Lewis procedure. And the first part of the procedure entails a mobilization of the stomach to make a gastric conduit first. And the biggest challenge initially when people were trying to do these surgeries laparoscopically was that lots of questions were being asked about whether you're having removing the tumor adequately, whether you're doing adequate lymph node dissection. So there you can see the dissection is being done between the hepatic artery, which is being laid bare. You can see that's the hepatic artery below, and all the tissue is being removed completely clear of the vessels to ensure that, again, you see that's the pancreas and all the lymphovascular. You can see that's the hepatic artery below, and all the tissue is being removed completely clear of the vessels to ensure that, again, you see that's the pancreas and all the lymphovascular tissue anterior to it is being cleared towards the specimen. So we can now do all these surgeries laparoscopically and ensuring that's the cleared out artery completely bare seen. There you can see that, and that's where we'll reach the left gastric artery. And again, small dissection very carefully, just like people used to do in earlier times with open surgery, and even today we do in open surgery sometimes. you just divide the vessels, and then that will be followed by completion of the gastric mobilization. And once that is completed, we will divide the, that's the chest part which is started now. So we made a conduit from the stomach. That's the chest part which is started now. So we made a conduit from the stomach to get it into the chest. And that's the mobilization of the lung, the esophagus now. The lung is this. So we now do our esophagectomies in prone position. We've now learned that esophagectomies can be done with one lung ventilation. So even patients who have borderline lung functions, they can also undergo an esophagectomy without the need for a single human. You learned that esophagectomies can be done with one lung ventilation. So even patients who have borderline lung functions, they can also undergo an esophagectomy without the need for a single human tube, one lung ventilation. The lung just falls down with gravity, and then you use a little bit of carbon dioxide pneumothorax in the chest to ensure there is enough space to work. And that's where the esophagus is being mobilized. And then once that's the division of the esophagus, and once that is done, we divide the last bit of the stomach. That's the stomach which has been pulled into the chest. You can see the staple line has partially been created already, and the remaining part of the stomach is being divided. So far, the stomach last part was not divided so that we could pull that stomach into the chest, because if we had divided, the stomach would stay back in the chest even if we pull the esophagus. And that's the anastomosis being created. Small and esophagotomy and a small gastrotomy made, and a stapled anastomosis followed by. So this video essentially highlights that something which was once considered very, very formidable, even as an open surgery, is now being very, very routinely done with minimally invasive techniques. The suturing, everything is being done laparoscopically, and the skill set as well as the knowledge of anatomy, which is required to do these surgeries, is gradually becoming more and more available. And what we achieve is that you have a patient who's walking in the ward the next day after surgery very comfortably. The patient gets the benefit of discharge early on. So the 6-7 day, quite many of the patients will be going home. And the benefits of early recovery are seen in the ability of the patient to join back work, or sometimes in these patients to start their adjuvant treatment also faster, thereby reducing the total duration of the treatment. Coming to pancreatic surgery, so this is a young lady who's undergone a distal pancreatectomy for a pancreatic body tumor. And as you can see, it's a biggish tumor, starts off with division of the omentum. And then you'll see quite many of, if I know there are some surgeons, Dr. Joyal is also there. Just like in open surgery, that fine dissection can be done very well laparoscopically. The advantage of laparoscopy is that you get a very good magnification and you get light exactly where you are working. So light is not over the surgeon's head. The light is exactly where we are working, and that's where you see such bright illumination. There is nobody, no assistant's head coming in the way to prevent you from having a look at what's happening. So that's the small artery which is going into the mesocolon from there. That's a pancreatic tumor. And there we are dissecting. All the lymphovascular tissue is being taken along the vessels. That's the celiac trunk. The hepatic artery is this side. And very soon, once we dissect, you'll see the splenic artery here. And that's completely bared. All the lymphovascular tissue has been taken. So you can use a tire, normal, regular clip. You don't need fancy stuff there most of the times. So the only place where we'll use a stapler in a distal pancreatectomy would be to divide the pancreas. And there you see fine bits, very, very fine dissection being done with simple instruments which are also used for a laparoscopic cholecystectomy. That's the splenic vein being divided right now. That's being clipped. This will be followed by division. That's the tunnel being created behind the normal pancreas to divide the pancreas. And this will be followed by division of the pancreas. And then in the end, the splenic artery has also been divided, which had been ligated earlier. And then again, that's entire specimen is put in a bag to avoid contamination of the wound. That's a bag being placed, and this will be followed by a drain placement. Now again, what do we achieve? We achieve the same oncological specimens by doing these surgeries laparoscopically. And you can see the incisions there, small cuts instead of a big midline laparotomy, or an incision which would be cutting through all the muscles in the upper abdomen to just get an access to that part of the pancreas or that part of the tumor. Coming to surgeries for colorectal cancer, that's the last two videos which I'm going to show. So, lot of surgeons, I'm sure, here must be doing right hemiclectomies for a lot of benign indications. This video highlights two things. That You can do surgery even for cancer laparoscopically. The important thing there is that one has to have a sound knowledge of oncological principles. The vessels division, the lymph node dissection, all has to remain the same as you would do for an open surgery. So that's the entire colon which has been lifted up to the right side of the patient. And we start dissecting. So we have concepts in colon cancer surgery, which is called a complete mesocolic excision and central vascular ligation, which ensures that we are removing all the possible areas where there could be microscopic disease, where it is likely to be. And now, important thing ensures that we are removing all the possible areas where there could be microscopic disease, where it is likely to be. And now, important thing in oncology is what we have to understand, that as of now, our knowledge is actually kind of limited by what we see on imaging, sometimes what we see on pathology. In oncology, an important thing to understand is that the survival depends on not what we have removed, but what we have left behind. And quite often, it will be a situation wherein we have not thing to understand is that the survival depends on not what we have removed, but what we have left behind. And quite often, it will be a situation wherein we have not understood that there are some lymph nodes at the origin of vessels. So there you can see cleaned off bare vessels where possibly there could be lymph nodes or the lymph nodes could be involved, and you're completely taking them off. So that's the SMA and the origin of the middle colic artery, which is being completely dissected, bared off of all lymphovascular tissue to just ensure that the entire lymph nodes in that area come with the specimen and are not left behind in the patient. What this has led us achieve is that we always get an adequate lymph nodes. We need to have at least 15 lymph nodes in a colorectal cancer surgery, and our median yield for lymph nodes in our colorectal cancer surgeries is about 40. So that's the kind of lymphnectomy which can be achieved with laparoscopy. The vision that we get, and there's a magnification in the laparoscope, which helps us ensure that we are less scared now of going close to the vessels, because seeing that tissue separately, the vessel separately, and that's how the surgery is being done. And now what we do is that even the anastomosis part is done laparoscopically after division of the bowel. And there you can see use of sutures, intracorporeal suturing, as well as stapling techniques helps us do these anastomosis as well. And what we get by all this, that's the anastomosis being completed. And there you can see that small entrapment, you can very comfortably suture this laparoscopically as well. Obviously, robot makes it a bit more simpler to do it, but then with laparoscopy, as you keep doing these surgeries, you get better and better at them, and that's the specimen being marked with a suture to get that out. Now, what we achieve is that this is a patient next day after surgery. You can see third day after surgery, the patient is getting discharged, and these are the actual incisions. You obviously need a 3 to 4 centimeter incision somewhere on the belly to take it out. What we've realized is that phalangeal incision, the same way as you see very few hernias in a phalangeal, LSCS, the same way we see very few hernias or wound infections in phalangeal when we take out a specimen. So majority of the patients in whom now we do our laparoscopic cancer surgeries, we take out the specimen from a small phalangeal incision, heals beautifully, less pain, hernia, very, very rare in that hernia. And then you can see here adequate number of lymph nodes, and the patient recovering faster ensures that the patient get their further treatment done timely and then complete their treatment also timely. This is a young lady who's received neoadjuvant chemoradiation for a distal rectal cancer. And this video will show you how, if some of you remember from your MBBS days or from your surgery times, that when your professor, our professor, even my professors, when they used to do these pelvic surgeries, days or from your surgery times, that when your professor, our professor, even my professors, when they used to do these pelvic surgeries, I'm not sure what they were seeing actually. And as an assistant, I never saw anything. Because the moment somebody brings their head, the light is gone. And you just can't see anything. And at a certain level in the pelvis, you would lose practically all vision. Even the surgeon would be operating blind. With laparoscope, the advantage is that your vision is at the end of scope. So that's where you get your vision from. That's where you get the light inside the belly. And you start off with the initial laparoscopy. I think I'll just take over to the anatomy part. Very nice delineation of all the important structures. That's the fine dissection being done. And you see, this is a monopolar cautery being used. We would use bipolar sealing devices. I would be lying if I say we don't, but we do them much less often now. It is used only at specific places where we need to. Very clear delineation of the anatomy, gonadal vein, everything being seen. And we can now go down very close to the origin of the artery. That's the aorta, and from there you can see the IMA arising. And the entire origin of that area has been seen clear. Now, at this step, I can tell you from my open surgery experience and my training that deep down in the pelvis, even the surgeon was largely blind. But when we do these surgeries laparoscopically, we get to see a lot of this area. So there you can see very, very fine dissection being done, small bursts of current, just like you would use your open cautery in open surgery. The same way the laparoscopic instruments work very well. You take off all the fat with the specimen, and then once that is done, you just go down, thin out the rectum, and there you can see every bit is seen very, very clearly. There is not a part of the surgery which is blind to either you or your assistant, because whatever we may say, errors happen in surgery, complications happen. But if three people at the same time are being able to see clearly what is being done, the chances of errors happening goes down. And so if you are going wrong somewhere, your assistant can see. If you have a doubt about the structure, you can ask your assistant to see. You can call a colleague to have a look. And there you are very sure as to what exactly. So that's the vagina being separated anteriorly from the rectum. And there you can see very, very finely all that dissection can be done to ensure that the safety of surrounding structures is not compromised. You have an exact vision what you are doing. You are doing complete removals of the cancer as is supposed to be done. And that's a thinned out rectum ready for the rectal division. And that's the some bit of technical part of splenic flexure mobilization being done to ensure that the colon, which we are going to anastomose, reaches down to the pelvis. That's the ileostomy site being marked. And once that is done, same phalangeal incision, the specimen comes out, and then you put the circular stapler back in. Anastomosis, everything is being done absolutely under vision. You don't have kind of assistants who are struggling to just kind of show you something. You can very well have a very good vision. And that's what we get by doing these surgeries laparoscopically. So to summarize, what I would like to say is two things. One is that there is a very important role of DMG based, that is organ system specific surgery being done in oncology. And that is what is kind of, I believe that that is what helps us do what is being done at the best centers across the world. And the replication becomes simpler. You are there in terms of your knowledge. You are focusing on a certain specific field. And then when we talk about oncosurgery, there is a lot of role of minimizing the invasiveness. It definitely improves outcomes. And obviously, none of this is possible without a teamwork. Our medical oncologist is going to speak next. My team at Max Specialty takes care of our patients. I would say a heartfelt thanks to all of you for coming to us this Sunday morning and listening to this talk. Thank you very much.
First of all, I would like to thank Dr. Mangla on behalf of IMA Haldwani for giving a valuable information about advanced minimal surgery for GI malignancy, such as lap surgeries for pancreatic tumor, for colon carcinoma, CA esophagus, and also about the benefits of minimal invasive surgery over open surgery. Thank you. Any questions from the audience? Any questions from the audience?
Sir, as far as ripples of pancreaticoduodenectomy is concerned,
Like for periampler is here.
so some ripples are being done laparoscopically, but then when we talk about ripples being done laparoscopically or now robotically, it is also kind of, it is done very, very selectively. So what I've shown you is scenarios wherein, so even we do sometimes ripples laparoscopically, but we are very selective. A small tumor, relatively younger, fitter patient, because the operating time increases significantly. So
But
when
mostly it's being doing open.
mostly it
surgery.
is now still being done by open techniques, but yes, it is being done at some centers selectively. And even we do it sometimes with laparoscopic techniques. The surgeries I showed you are 4 surgeries or 4 areas which are kind of being done regularly in majority of the cases. So if you ask us, less than 5% of our colorectal resections now would be open. There would be situations wherein patient has 4 or 5 previous surgeries, second surgery, third surgery, lot of adhesions, intraoperative difficulty in identification. But otherwise, these are 4 scenarios: esophageal cancer, pancreatic tumors, colon cancer, rectal cancer. They would by and large be treated laparoscopically. Sir.
Excellent presentation, Dr. Mangla. I have one query. When you step in esophageectomy, and then you reinforce it with laparoscopic surgery.
Sorry?
After stapling device application and
Yeah.
anastomosis,
Yeah.
then you reinforce it with suturing.
No.
laparoscopic.
So basically, what So whenever we do our laparoscopic anastomosis, majority of the anastomosis will be done in such a way that the two sides to be anastomosed would be divided with staplers, and then you would keep them side by side, but you need small kind of places to enter those two lumens to make that anastomosis. So what we would do is we will make a small opening in the esophagus and stomach, as Dr. Saab is talking about, and then put a stapler and anastomose. But we have that opening in the esophagus and the stomach through which we put the stapler. That will have to be suture closed.
Right.
And sometimes people use a stapler as well. So that bit will have to be sutured. And sometimes we also do the entire thing by suturing as well, but the stapler does save time.
Not like in gastrectomy where we do those bariatric surgery procedures where we do routine reinforcement. Yeah.
So I think what you're talking about essentially is that some people do reinforce. For example, you're doing a sleeve gastrectomy.
Yes, sleeve. Yeah.
So when we're doing the sleeve gastrectomy, we have to understand that sleeve is a very specific case scenario. I think beyond the purview, but I can answer this. So sleeve is a very high pressure zone.
Yes.
Your stomach was a huge organ. You've made it half. There is a functioning sphincter at the end of it. So sleeve becomes a high pressure zone prone to leak. That is why there is some data that reinforcing helps. But majority of the anastomosis, even in bariatric surgery, people would not reinforce the anastomosis. But yes, when you've done a stapled anastomosis, you will have small enterotomies to close. That would have to be done with suture.
Thank you.
So standard treatment for the cancers remains the same. So when we talk about this patient who had esophageal cancer surgery, this patient had a long course or neoadjuvant chemoradiotherapy, standard carbopacli, that's the chemotherapy drugs with the radiation 45 degrees. Talked about the rectum again had neoadjuvant radiation. So the indication for neoadjuvant treatments is well established. Practically speaking, almost all esophageal cancers will have preoperative chemotherapy or chemoradiotherapy. Majority of the rectal cancers will have preoperative chemo or radiotherapy. Selectively, pancreatic cancers will have preoperative chemotherapy and postoperative chemotherapy. And the colon, by and large, most patients will have postoperative chemotherapy if they have stage 3 or more disease. So practically, when you look at 4 patients, 2 of them received both pre and post. 1 patient received post-surgery chemotherapy. Thank you, please.
Thank you, sir, for a wonderful and an interactive session. I would like to invite the chairpersons to felicitate the speaker, please. I would like to call upon the dais Dr. B.C. Pandey, sir, to felicitate the chairpersons, please. Thank you, sir. The next lecture is Robotic Lung Surgery, Future is Certain, and the speaker is Dr. Pramod Jindal, Director, Thoracic and Robotic Thoracic Surgery, Max Super Speciality Hospital, Vishali. And I would like to call upon the stage Dr. Manoj Batra, sir, Dr. MC Joshi, sir, and Dr. S.K. Gupta, sir, from Bajpur to chair the session, please. Dr. Manoj Batra, sir, Dr. MC Joshi, sir, and Dr. S.K. Gupta, sir, from Bajpur, please.
Yes. Okay. Uh, Thank you, I am Haldwani, for giving me a chance. Uh, may I request everyone at the back? May I request everyone at the back, just give us a few minutes. I won't show anything medical. I'll just show you a clipping of a tennis match. आज विंबलडन हो रहा है. Let's see a tennis match. So this is one of our patients who underwent lobectomy robotically, and the person with the black shirt, and he's playing tennis after exact 18 days of surgery. So after, so that is the change what has happened in last 25 years, when probably some thoracic surgeon thought that VATS lobectomy or minimally invasive lobectomy can be done. Thank you. I am Dr. Jindal from Max Super Specialty Hospital, Vaishali, and I am a thoracic and a lung transplant surgeon. This is a video which I got from my friend 2 days earlier. He is a thoracic surgeon at China, Shanghai Hospital. Just listen to him, what is he saying? Can they get? This is a lobectomy which is done by robotic, and this is just after 2 hours of extubation. And this is not a simple lobectomy. This is a lobectomy where a part of bronchus has been removed and then sutured. So 2 hours में sedation खत्म नहीं होता, and the person is walking after a single lung ventilation. So you can understand the things have changed from what was a dreaded surgery till now. Now let's see what are the organs we operate. The organs we operate are anteriorly thymus, lungs, airway, anything, but except for heart, I can operate anything in the chest. Heart, Weber will tell you more. What do we operate? Tuberculosis, which is very rampant over here. Infectious, yes. Anything, empymas or whatever can be done. And then obviously tumors, which are very well done, very well required to do by robotics. And that are the bulk of the surgeries where robot comes beneficial. Open 18-inch incision, everyone has seen sometime in their life. Means any of your patient you must have seen, but those are pretty bad. If you see after 5 years, it is he can't move or it is difficult. VATS, small incisions, it is better. But yes, many of you must have started from that Lambretta scooter. Now you have Mercedes. It is the eventual history what we all are going through. And maybe someday I'll show you the last slide. You will see the spaceship, the Chandrayaan of our thoracic surgery. Thoracotomy to multiportal VATS to robotic, what is known as robotic assisted thoracic surgery or RATS. These are the two guys who mentored me, Dr. John Mitchell and Agustin, and they were the ones who taught me thoracic surgery and robotic thoracic. This is the system which we work on, which is the Da Vinci system, the XL system, which is the latest. And in robotic, the best part is that you can go into any corner of the thorax. And remember, thorax is very, very good when we think of robot because the lung collapses and you have got the entire playground, football field over there to do the surgery. So, sorry, yeah. And as you can see, we can do thymus, we can do tumors, and every part of thorax can be done by robotic. Regarding the type of diseases, thymectomies are no-brainer. You can actually do it very beautifully. Thymomas, myasthenia gravis, whatever it is. Diaphragm, whether it is hernia, eventration, everything can be done. We show you. Lung cancers world over, maximum number of robotic surgeries are done for lung cancers and mediastinal masses. There can be done. Yes, there is a thing that a certain size, after a certain size, it becomes not that beneficial. Advantages: once you have driven an automatic car, particularly a higher sedan, you will understand the difficulty of changing the gears. And the same thing happens with your robotic systems. One, you have had the comfort of sitting down, seeing 3D and operating, the surgeon's life becomes easy. And I can tell you, as a surgeon, I also want my surgical career to be extended. Robot makes a good surgeon better, an average surgeon better. So it eases your technical expertise also, because it takes out your tremors, so you can operate till a longer time. But the most important benefit is for the patients. Patient, as you can see, they get less bleeding, less pain, and they go home very early. My robotic lobectomy goes home the second day, whereas VATS would go on to the third day. And if I do an open, it might take 5 to 6 days, because his chest dynamics are not working, his lungs are not inflated completely. I'll show very few videos. What you have to see in these videos is the finesse you can achieve uh, uh, by robotic. So this is the lymph nodal dissection. You can see what Vivek also told, that we remove a single lymph node and very fine dissection. This is when you do a lung cancer, the lymph nodal dissection is the most important. This is the lower end. Now comes the difficult end. So the benefit is, once you do a surgery, you take out the entire nodes slowly and gradually. And remember, these are millimeter. You cannot take 2 or 3 millimeter. This is near the trachea, the bifurcation of the trachea, where you are removing all these lymph nodes. So in cancer, one of the most important thing is that removal of the lymph nodes. And you can understand that even if you see, okay, this is the vessel, you can stop over there, suction it completely, and then go ahead again. So the most important thing of any robotic surgery is the precision of your steps. And you can see, it is not, you don't see that there are tremors or anywhere. Now on the right hand side, you can see the lung is there. On the lower hand side, you can see there is the trachea. So what you are doing, or the bronchus, and there is a vein on the right hand side. You can use gauzes, you can use simply. The vision is better. The vision in robotic as compared to vascular is better. So you can understand, if the vision is better, the tremors are less, the technique is precise, the operation has to be better. And therefore, the air leak, or what we say, the post-operative air leak, is less. Therefore, the patient goes home sooner. Sorry. The next, I'll show you how this is a thymectomy. Now, as you can see, the lower part is the heart, wherein the entire, you have to take the thymus gland from the heart. It is a very, I won't say a very narrow space, but it's a very small space which you have to a little enlarge. The beauty is that in myasthenia gravis or in thymic tumor, you need to take out the complete thymus. The bleeding is least because you are going slowly but efficiently. So once the bleeding is less, dissection is better, the complete removal of the gland is there. And what you can see is that we are removing from one area, from left side, we are also dissecting on the right side. So you can go from here to here, and you can see the lower part, which is basically the pericardium. In upper part, you will see the origin of the arch of aorta, and you can take out the complete thymus. And removal, if you remove the complete thymus, which is a radical thymectomy, the chances the patient will be relieved of myasthenia gravis is more. This is the brachiocephalic vein from which you are removing the thymus. It's very difficult. The precision becomes better when you know that there the cautery won't be dispersed or so. And it is basically the better removal of thymus leads to better post-operative outcome. Sorry. This is what you commonly see is the diaphragm has become weak. This is eventration of diaphragm. I'm not going to show you the surgery over here. This is basically to show that the type of knotting you do, the type of suturing you do is so good by robot. So if given an option, VATS is robot is much easier, better for these kind of surgeries. As you can see, the way the needle is being holded, it's very difficult to do by VATS in this. This is a surgery wherein आपको चुन्नट डालनी होती है. It's like making a pallu, and you have to do the same with the diaphragm because it is thinned out, and you do it. And what it's not a very rocket science to do over here. You just have to take multiple layers of sutures and sutures and sutures. So maybe one eventation I would have to suture around 25 to 30 knots. The problem is after tying, many a laparoscopic surgeon will know that after tying 5 to 10 knots, your hands get tired. They do get tired. So the efficiency of the knot decreases over a period of time from starting to end. But in robot, that is not over there. And you can see the way the needle is moving, everything works fine with this. And that is all what I wanted to show over here. That diaphragm is a wonderful area to be operated or to be done surgery by robotic systems. I'll end over this video, and I'll show you the same thing a little trickier. So you see, this is we are removing single lymph nodes. This is we are dissecting over the arch of aorta and trying to remove the lymph nodes. Using a cautery by VATS sometimes because the movement of the patient and everything becomes difficult. But this below is the carina from the left side. So once you remove these all lymph nodes, the N2 disease, the N1 disease, whenever you operate, the post-operatively, the chemotherapy, they all are easier, much better effective. So if I have to go behind the vessel and do it like this, holding my finger, it is much easier to do by robotic systems. So that is something what we have been doing, and we find it much better and easier to do by robot. This is something I'll show you. If you have to hammer, I'll just stop and ask you. If someone has to hammer a nail in the roof, imagine how difficult it is. Something like this. And if you have to take out the slab from here, it is quite difficult. Sometimes we have to remove the intercostal muscle from the roof. Now you see, I'm operating, my patient is like this, I'm operating it like this. And we are taking the intercostal muscle graft from the roof of the room. And this is so easy, and you can see the intercostal nerve which is by the side, and then you take it out and suture it down. So operating at any point becomes better. I'm saying it is not that we cannot do it by VATS or so, we can, but the technique gets better, the outcomes are better. That's the basic crux. And at the end of the day, what do you want? You want the entire tumor to be out. You want better functionality of the patient, and you want the tumor not to return, the suturing to be better. These small steps takes a lot good out of this surgery, and then we can. And this as well was telling you is the Chandrayaan, which was done a couple of months back. A complete lung transplant was done in Barcelona by robotic system. And in lung transplant, yes, it has been almost 40 years. We are actually going to have 40 years of lung transplant after 1983. Many of Many centers do lung transplant, but now the pinnacle of thoracic surgery is that you do a complete lung transplant, means you anastomose the entire bronchus, the entire pulmonary artery, entire pulmonary vein by robotic system. And I wish someday by your blessings, maybe we would be able to achieve something like this of this stature. And once the height is this, you can imagine that all the surgeries which are below this are much, much doable by robotic system. My entire thing is that in today's era, in 2023, what we need to see is what can be done further. How can we do it much better? Open to हम कर ही सकते हैं ना. So let's take another leap and do it better. And for in this better, I all invite you. We are going to have an update and management of tuberculosis on coming Saturday. We have got panel discussions. We have got 55 faculty pulmonologists coming over there and letting you know, discussing the basics of tuberculosis, which is still, we are going to do something robotic, but still our main focus is tuberculosis, as Dr. Joshi would agree to us. So this, I would be happy to have you over there in Delhi. And thank you. Thank you very much.
I would like to congratulate Dr. Pramod Jindal for such a nice presentation.
Thank you, sir.
And starting from the days of pneumonectomy, open pneumonectomy resections, tuberculosis patients,
yeah.
And now we have come forward for last 40 to 50 years. We have seen VATS and the robotic surgeries. There is a lot of development in these surgeries, and there is minimal complications. And with such a nice videos, he has elaborated most of these surgeries. And I once again congratulate and
thank you.
Request audience to ask any question if any doubts.
Thank you. Thank you, sir. As you have been supporting and everyone from Haldwani. Thank you. Thank you. Thank you.
Thank you, sir. I would like to ask the chairpersons to felicitate the speaker, please. Yeah. A big round of applause from the audience, please. I would like to invite Dr. Kusum Naryal, ma'am, to felicitate the speaker, the chief persons, please. Thank you, ma'am. What's new in cancer treatment? The next talk will be delivered by Dr. Professor Minu Walia, ma'am, Senior Director and Head of the Department, Medical Oncology and Hematology, Max Super Speciality Hospital, Parparganj, Vishali, and Noida. I would like to call upon the dais Dr. Mohan Sati, sir, Dr. N.S. Bhatt, sir, and Dr. Virendra Singh, sir, to chair the session, please. Dr. Mohan Sati, sir, Dr. N.S. Bhatt, sir, and Dr. Virendra Singh, sir.
You have a point.
Yes, madam, start.
So, with permission from the chairpersons, without much ado, I would come straight to the topic. What's new in cancer treatment? Cancer? Any wild guesses? How old is cancer? Anybody from the hall? How old we think is the disease cancer? Anybody can volunteer? जोर से बोल लो. Yeah, we can all hear. Yeah, the slide shows it. So it is not only just a few hundred years old story that we are talking of. We are actually talking about cancer, the first, what we are talking about 3000 years before Christ. And 3000 years before Christ, what we are talking of is the documented evidence of cancer. So this is an Egyptian textbook, that is the world's oldest textbook of surgery written by Edwin Papyrus, that actually described 8 cases of breast tumor. And at that time, the treatment, what it said was cauterization or fire drill, which we now think was something like cauterization. And the same textbook had a very chilling sentence that said, there is no treatment for this disease. That is what I think most people believe even now. But what has happened actually is a lot has happened for this disease. A lot has happened in the evolution of treatment of cancer. So we have been doing lot many things. Even in at 3000 years, at that point of time, what was being done was the local treatment. The local treatment in the form of surgery being the prototype of the treatment for cancer that was done. Even our Indian ancient scriptures, like Sushruta, one of the oldest surgeons, in Arth Shastra, there is a mention about Sushruta saying that about disease, which is cancer, which looks similar to cancer, the growth ho jati hai, and the only treatment for this disease is the term used is ang bhang. Ang bhang is the only treatment, and that is like cutting off that part. So that was at that point of time where a lot of focus was on the local treatments. Then came radiation, and then came systemic therapies and whatnot. But what has happened in recent times? How things have changed? What has actually has changed is the realization of the fact that cancer is a systemic disease to begin with. If we all go back to our pathology books, what is the hallmark of cancer? One of the hallmark signature of cancer cells is non-addition, non-cohesion, and metastasis, ability to metastasize. So all these cells are not united together. They don't adhere to each other and have a tendency to metastasize. And that is why even when cancer appears localized to the eye, it appears as a tumor on a scan. It is not actually localized. It has micrometastasis all over the body. And that is the reason when we try to address most of these cancers with local therapy alone, we find that invariably relapses happens and cure never happens. And that is why the disease keeps on coming back and we were not able to give the best of survivors. A simple example like osteosarcoma. At one point of time, the only treatment for osteosarcoma, the bone tumor, was surgery. But in spite of the best of surgeries and best of outcomes, the overall 5-year survival, not beyond 50%. Half of these patients used to die. These young boys and girls used to die. Osteosarcoma, we all know, happens in the younger age group mainly. Also, there is another peak at the older age group. But then what happened, what we found is after surgery, if you add chemo or some kind of systemic therapy, the survivals improved to the tune of 70%. So you could do a lot of difference. And what was happening is we were trying to give some medicine for these micrometastases. And in today's state, what is new is you want to take care of this micrometastasis early in the disease course. Even when it is operable, osteosarcoma, you want to give chemo upfront, then do surgery, and then look for any residual disease, because if there are any resistant cells, you want to change your gear. You want to change your weapon against cancer after surgery, because there might be some resistant cells which would have escaped chemo, and then you want to give something further. And nowadays, you see cures to the tune of 90%. A simple change in sequence have made so much of difference. And the same is happening for breast cancer also. Today, more than two-thirds of the breast cancers, even when it is operable, we try to give systemic therapy upfront, then do surgery, want to look at the residual disease, how much of the disease remains behind, and if required, change your gears or change your weapon against cancer so that you can improve the survivals. So this is in short how things have changed, how the concept have changed, and these systemic therapies, again, the prototype has been mustard gas, which was an accidental discovery in World War One, then used in World War Two, and from there we have come a very, very long way. There are so many different chemotherapeutic agents which are available. We have been using various combinations to overcome resistance, and beyond the ages, beyond these centuries, there are so many agents. So chemotherapy is also not one drug. We have more than 200, 300 different agents. But what was being realized is, in spite of the best of the chemo agents, the 5 year survival, we had come to a plateau. And then what was realized that we have to move on to the new era, and this new era is the era of precision medicine, that every disease has a genetic abnormality as a basis. Although first recognized for sickle cell anemia, but answer was found in oncology. And where we came up with the cancer bullets or the magic bullets. Sir Paul Ehrlich, a famous British scientist, came up with the idea that if you can split parts of the cell differently, you can even have different drugs to adhere to different cells. Because earlier than that, chemo cannot distinguish between a bad cell and a good cell. It will kill all the cells which are rapidly dividing. Once he came up with this idea, and then came the first magic bullet or targeted therapy in oncology that was targeting the abnormality at the grassroots level, the BCR ABL abnormality or CML. So before that, the only treatment for chronic myeloid leukemia was bone marrow transplant, and we knew that even at the best of the centers, even after the bone marrow transplant at the best of the centers, the survival was limited, lot of toxicity. But after the advent of this targeted medicine, today a simple oral tablet, and patients survive not in months, patients survive in decades. We have patients, all of us are having patients who are surviving more than 1 or 2 decades, almost being cured, that we now talk of even stopping these therapies. Last but not the another example of targeted therapy is identifying the target. Earlier, we did not know the target we were hitting in the dark. For example, breast cancer cells. This is one of the target which has been identified in breast cancer cells, which is known as HER2/neu. Earlier, when it was a HER2/neu positive cancer, we used to give a very dismal prognosis for our patients, and we would tell them, because these were more aggressive cancers, they will metastasize faster, relapses were more common, brain mets was common. But ever since the discovery of a targeted therapy for this target, we know that these patients, they do much well, much better than the normal patients also. Last but not the least, the last kid on the block is now immunotherapy. So, is immunotherapy something new for oncology? The answer is no. We have been using, but we never concentrated and knew the science behind, and that was all unorganized. So, again, the credit goes to Sir William Coley, who realized that one of his young patients, a young girl with advanced sarcoma, she had advanced disease, but when she developed fever, and then her tumors, the mets on the skin, the nodules regressed. Once she developed fever, any other febrile illness. So what he came up with the idea was that he developed his own concoction, which was a culture in his own lab, toxin, and he started inserting it into his patients and found, he named this as Coley's toxin, and he found that these patients, when they were given, patients of advanced cancer were given Coley's toxin, somehow the tumor would regress. So something was happening in the body when fever used to happen. He had even published a series which was published in New York Times of 150 patients, at that point of time, claiming that things could move with immunotherapy. However, immunotherapy, since we did not know what was working, it never gained space till this last decade. Rather, 2 to 3 years back, the Nobel Prize for Medicine went to the discovery of immuno-oncology. So, what is immuno-oncology? We know that when there are cancer cells, they express tumor antigens. There will be recruitment of T cells which will go and kill these cells. If the process was so simple, then why did cancer develop? Because this process does not happen. Why it does not happen? Because cancer cells are very smart cells. They develop ways in which to evade the body's immune responses. So, in simple words, they develop a mask, they escape from the body's immune processes or the cytotoxic T cells, and cytotoxic T cells are not able to recognize the cancer cells from the body's normal cells. But now, with immuno-oncology, we have monoclonal antibodies which expose these cancer cells to the body's immune processes, and you can see wonderful results in some of the cancers where chemo never used to work, something like malignant melanoma. There was a time when we would say malignant melanoma, advanced malignant melanoma, median survival 3 months. Today we see patients surviving for years. Same like renal cell carcinoma. So cancer immunotherapy has come a very, very long way. Who could have thought of a vaccination to prevent cancer? We have a vaccine today, again a process of immunotherapy to prevent cervical cancer. And the present era is the era of immuno-oncology, a lot of maps, nanotechnology, and lot of new molecules. And in today's date, I will rather say it is a personalized cancer treatment. In a similar fashion that A, B, C, D are not the same individuals, even if they have the same cancer, the same histology of cancer, and the same stage of cancer. Let me say, if all of them had stage 4 lung cancer, if all of them have a stage 4 adenocarcinoma lung cancer, even then every patient is different. It is very much possible that patient A is given no chemotherapy because his testing tell us there is a target and you give one targeted therapy or simple oral tablets, no chemo required, and patient does very well. Patient B, no target, we have to resort to chemotherapy. Patient C, a target very different than the patient A, and again a simple oral tablet, but a very different tablet. And patient D, probably no target, no chemo, but have a very high expression of PDL1, which will tell me that this patient will do very well to immunotherapy, and you give immunotherapy injections and patient survives for years altogether. So this is how oncology has changed and what is new in cancer treatment. And just I'll be very brief, show a few cases where it is seeing is believing. So this was a patient, 63-year-old lady who was detected to have breast cancer. So this was a corporate checkup in one of the corporate health hospitals. And this was to her son, where parents were covered. He got a corporate checkup done and was detected to have a breast mass on mammo, and ultrasound abdomen showed liver as well. So biopsy from the breast was positive for cancer, and even FNAC was positive for cancer. So what I'll say, this was a baseline PET scan. This was way back in 2013. We can see the breast mass, and we can also see the multiple liver mets here, the liver mets that was seen. So textbook wise, a postmenopausal lady, metastatic CA breast with liver mets, median survival, not beyond 6 months. That is what we were taught, and that is what we would tell to a patient in a OPD practice. But let's see what happened to the patient. Fortunately for her, we could find a target and we could give her chemo along with that target. And after 6 cycles of target, you can see what happened in the PET scan. This is not working. So on the right side is the baseline PET CT. On the left side is the comparison. Can you give me another one, please? On the left side, you can see there is a complete disappearance of the breast mass and no liver mets at all. We also had never seen these kind of results. And it was a PET set. It is a complete response. The cancer has gone. We did not know what to do. We never knew that breast cancer with liver mets it can actually disappear. So there was a very heated discussion in a tumor board for a very, very long time on this case. Shall we offer surgery for this patient or no? So what will the house say? Shall we offer surgery for this patient or no? So the house was divided. Even our house was divided. We did not think of surgery, but the patient insisted, let me get the surgery done. We got the surgery done, and in the after surgery, in spite of the PET showing no evidence of disease, there was a 2 millimeter residual tumor in the breast. So lesson number one, even if the PET is negative, there may still be micrometastasis, there may be still be disease. But after that, the patient has been on follow-up receiving targeted therapy and their subsequent PETs. You can see I've not shown all the PET scan. What I will do is show the one of the PET scans that was 2015. This is again not working. Excuse me, this is not working. 2015, and then the latest one in June only. And again, you see no evidence of the disease. So we have come a very, very long way. Metastatic CA breast with liver mets, expected survival not beyond 6 months, and the lady is surviving almost 10 years. And she is not surviving in a bedridden condition bound to bed. What most people think is chemo hoega, treatment hoega, patient will be reduced to being a bedridden state. This is what the picture, the last year picture when every year for our cancer patients, we have a fashion show, ramp walk, these kind of events. And she participated in that fashion show. And she is a useful, productive member of the society. She is up and above, does all her duties, just like you and me, and not only in surviving with metastatic breast cancer beyond 10 years. Again, another patient, this was a 70-year-old male, probably being told one of from a smaller cities, rushed to the almost the best hospital of the country, being told that he had metastatic cell lung with brain mets. I'm not going to go into the details for lack of time. So small cell carcinoma lung with brain mets. Again, the prognosis he was told at the local place was, we will not see this patient beyond 3 months. So the patient, when he walked to my OPD, was on a stretcher with hemiparesis, bedridden condition, was, there was complete, almost complete hemiparesis, was dependent on his attendance for everything. So I'm not going to go to the details. We did radiation, then gave chemo, and again we can see the PET scan from the right side is the baseline PET scan where you can see the lung mets. I'm not having the MRI films here. And here you can see the scan where it is again a metabolic resolution. The lung disease still exists, but much less than what it was earlier. And remission. So again, to cut the long story short, he had progression after 2 years. Then I had to resort to change gears. I had to start this patient on immunotherapy and such an aggressive cancer with brain mets. So this is the video of the patient. Again, 70 plus, 73 when he was diagnosed. Bedridden patient, frank hemiparesis, comes walking to the OPD and a useful member of the society. As age which permit, he still walks around, does all his own work on his own, and so he's passed more than 6 years. Again, another patient. This was what she came with, advanced CA breast. And this is something which is very common. You and me would have seen ladies coming with such a huge ulcer in the breast. Baseline PET CT, again, metastatic disease, bony mets, lung mets. Again, she was fortunate. I will rather say both the patient and the doctor was fortunate. I was also fortunate. We could find a target in her and we did not have to give her chemotherapy. Only simple hormonal therapy and oral tablets. And you see, 1 month of starting the targeted therapy, this was the baseline, and that was after 1 month the ulcer had started healing. And these are subsequent pictures. And this is what the picture is last. The ulcer has completely healed and the pet is in remission. So many years advanced disease. And again, this is one of the pictures I asked her to send only 2 days back. I have to make a presentation. Can you kindly send me a picture of yours? And she sent a picture while she was cooking in the kitchen, making morning tea for her family members. Who would have thought of this few years back, 5 years back, when we would have come? And my last case, for lack of time, again, And advanced cancer, again, I'm not going to go into the details. We all are very wary of head and neck cancers. He has been through multiple lines of chemo, various centers across PGI, Chandigarh, North India, but no response. Surgery had been done, radiation and everything. So this was what he came to us. So this was a call from our emergency that a patient has come bleeding to the emergency, has come from some part of some, he had come from somewhere from Punjab. So bleeding to the emergency and there's a huge mass and which is profusely bleeding. So the surgeons were called first, obviously, because he required carotid artery ligation and so many things were done. And however, the carotid artery ligation could not be done and carotid artery ablation was done. You've already seen from we have the best of the surgeons, a very good team at our center. And then nothing further. And we had actually given up this patient. And when I first saw the patient, I also told the same thing that we do not know. The patient is sitting on an atom bomb, whether it is few hours or few days. What it is, we do not know. The only thing that he has not been tried is immuno-oncology or immunotherapy. Let me do a marker test. Maybe he becomes a candidate. And we started, and the patient, the family agreed, and you can see the results of subsequent after starting immunotherapy. Everything, that huge ulcer disappeared. And today the patient again comes. This is again a video shot from the corridor of a hospital. He is not just living. A patient we thought he will not survive another day. He walks, he runs, he does all his household work. So I am not saying that we are able to give these kind of results to all our patients, but yes, these miracles used to happen once in a while earlier. This kind of percentage is now increasing, provided both the patient and the doctor are lucky and we are able to work the right way with a complete team, find a good histopath, right target, and probably the right sequencing of therapy. We can actually now making a difference in the cases in the lives of many patients, and this percentage of patients is subsequently increasing. And with that, I say thank you for a very patient listening.
Thank you, Dr. Saab, for the nice talk. Informative. Congratulations. Any questions from the audience?
Thank you, ma'am. It's very heartening to know that cancer, although carrying a very dismal prognosis, new things are coming up and we have hope. I would like the chairpersons to felicitate the speaker, please. I would like to call upon stage Dr. Alka Sati, ma'am, to felicitate the chairpersons, please. A big round of applause, please. Thank you, sir. Thank you, ma'am. I would like to bring to the attention of the audience that the UK RSSBI 2023, the fourth annual chapter conference, is going to be held in Nakutia Tal, Bhimtal, from 28th to 29th of October. The registration counters are at the behind. So please kindly register for the same. Thank you. The next topic of discussion is minimally invasive cardiac surgery. The speaker for the talk is Dr. Vaibhav Mishra, Director and Head CTBS, Max Super Speciality Hospital, Parparganj, Delhi. And I would like to call upon the dais Dr. Mohan Tiwari sir, Dr. Vijay Pant sir, and Dr. Dhirendra Mohan Gehlot sir to chair the session, please. Dr. Mohan Tiwari sir, Dr. Vijay Pant sir, Dr. Dhirendra Mohan Gehlot sir.
Now, hello. Now we are having a lecture by Dr. Vaibhav Mishra on minimal invasive cardiac surgery.
Thank you so much, and good afternoon, ladies and gentlemen. My name is Dr. Vaibhav Mishra. I am the Director and Head of Cardiac Surgery at Max Patparganj, and that's the 400-bedded super specialty hospital where I work. So, greetings from Max Healthcare. And as we have talked about the various advances in field of cardiology and surgeries before we, Dr. Jindal and Dr. Vivek Mangla took you through advances in GI surgery. But we have gone through these phases. We've seen the dial-up phones come to the smartphones, where the phone is not just our phone, but almost our wallet, map, and everything. So, what is the equivalent of this? It is the minimal invasive cardiac surgery. Now, minimal invasive cardiac surgery is a blanket term which includes all the cardiac surgeries done by it. But herein, we'll focus only on the bypass or the CABG, which is done through this route. So if you see on the left side of the screen is the cut for a standard surgery or sternotomy, and on the other side is the left-sided 5 centimeter cut through which a bypass is done. So various names, keyhole, MICS, but essentially done via 6 to 8 centimeters cut in left side of chest through for a CABG. For the valves, the cut comes on the right side of the chest. Now, the main thing is not the size of the cut. The other details of the operation, the anastomotic techniques, the particulars of bypass, they all remain the same. The only difference is how you access the heart. So instead of sternotomy, you are accessing the heart by the thoracotomy or a small thoracotomy. Now just remember this slide. After this slide, there are only videos. What is the difference? That in a normal CABG, we cut the breastbone with a saw, whereas MICS, we go in between the two ribs. There's retraction of cut edges of sternum, which is quite significant in a normal bypass. Here, the displacement of ribs is very, very minimal. Approximation there is by steel wires, which is a foreign body. Here is by simple stitches. Size of the cut doesn't matter. So I have put a small video which I'll just run through. This is a conventional sternotomy. And this is a saw which is used to create a surgically induced fracture of sternum. And so after this, we have access to heart. Obviously, after dividing the pericardium, now if you see the blood loss from the cut end of the bone, so no matter how quickest you do the surgery, this raw end of the bone will keep bleeding during the procedure, and that is how most of the people who undergo a bypass require blood transfusion. And now you see this big sternal spreader being placed over the retractor. Now this retractor will stay in place for about 2 hours of the surgery, 2.5 hours of the surgery roughly. And you can see the amount of retraction of the two ends of sternum which it is producing. Now similarly the closure. These are steel wires. About 6 to 8 steel wires are required. So pretty close to orthopedics. except for this part, except for opening and closing, the entire cardiac surgery is very, very graceful, very, very skillful. But these are the two steps which are quite grotesque. They look grotesque. Uh, but ultimately, all the incision heals well, and that's how it is done in a standard way. Now, if you contrast this with MICS, and I'll show you the video also, look at the size of the cut. It's about just 4 centimeter. The retraction, if you see between the cut edges of the bone, is very, very minimal, and that is the size of the cut. So this all is possible by use of special retractors or spreaders. The instruments which are used inside for performing the surgery are same as that of open surgery, but there are special set of retractors. I'll show you again. There's a bar which comes from the top, and there's another set of retractors. Two set of retractors. They open the chest in about 4 directions: up, bottom, sideways. Now contrast this. This is the old video. So contrast this with what you saw. Just a simple skin cut, dividing the subcutaneous tissue. Dividing subcutaneous tissue, and then the intercostal muscles, and you enter, and you have access to heart. You can see the heart beating. So we've just divided the chest wall muscles and the intercostal muscles, and we have access to heart. So very less traumatic, very less invasive. And if you see the size of the cut, again, contrasted with the medial sonography. The order of anastomosis here is a bit different. You can see, no doubt the operation is technically challenging. It's a bit difficult to perform. It may be painless for the patient, but it's quite painful for the surgeon, to be honest, because the space is very limited and nobody is able to. So this is the proximal anastomosis being performed on a beating heart. The operation is still done on a beating heart. And if you see, the normal octopus, which is a stabilization device, has been applied on the entire surface of the heart. And you see the internal memory artery is anastomosed to LED. Multiple grafts are possible, but we usually try to restrict the graft to 2 to 3 because otherwise the operative time is quite a lot. So still done on a beating heart using normal instruments. You can see the octopus over there, and the size of the cut again you can see. So this is one of the difficult grafts to perform. It is on the posterior surface of the heart called as posterior descending artery. You can see the vein graft being anastomosed over there. Some other intraoperative videos, but you will essentially see, through the small same size cut without dividing the sternum or the breastbone, we've been able to perform the surgeries. In many videos, you will see multiple grafts, at least more than 2. So there are a few prerequisites for this procedure. It is not like a standard sternotomy, which is universally applicable. One of them is a single lung ventilation, where means it entails putting a double lumen tube which will isolate one of the lung. So during the procedure, only your right lung works and your left lung is deflated, which would also mean that any patient who cannot tolerate a single lung ventilation will not be a candidate for this procedure. So anybody with advanced COPD, old age, and recently we have seen patients with COVID, anybody having poor lung function will not be able to perform, will not be able to tolerate this procedure. Here's a video, intraoperative video, where I'll see you I'll make you see the deflated lung. Anastomosis have been performed on the beating heart, and after this, when the video goes on the left side of the chest, you will see the deflated lung. The grafts on the surface of the aorta, the proximal anastomosis, the heart from the left side. So making this, so you can assume how important it is to have a deflated lung, without which the procedure will not be possible. There have been instances where we went to do this procedure, and because of additions, many other stuff, the single lung ventilation was not possible. Then the procedure has to be abandoned. So again, you can see there's a spreader. There's a special retractor coming from top. From it, there's one retractor, another retractor providing excellent exposure. I mean, exposure is not excellent, but it's enough to do the procedure. But you can see that I am the only one doing the procedure. There's no help. So with this procedure, again, the part of the technical challenge is that because the space is so limited, that it is essentially the surgeon performing the procedure. The assistant doesn't see anything, doesn't get to see anything, doesn't get to help you, that makes the procedure even challenging. So if you can see, it's only me who's performing the procedure, rest everybody's out of the field. And they have no idea what I'm doing, they can only follow the stitches. So obviously a steep thing to do. But in somebody like this is a 32-year-old patient who needed a bypass. In him, this will yield a fantastic result. There are some contraindications, as I said, there's not universally applicable technique. Anybody who's obese, bulky, large chest wall will not be a candidate for this surgery. Similarly, patients with poor heart or lung function will not be a candidate for this surgery. Poor target vessels. So anything which is suboptimal. So let's just put it this way: this procedure is a niche procedure. It's like a luxury car, and to drive a luxury car, you need good roads. So it can only be performed in patients who are fit and who have relatively preserved lung and heart function. So basic difference is it is the cutting of the breastbone or the sternum and not the size of the incision. And so when we are not cutting the sternum, it all translates to these 5 advantages. One is there's no blood loss during the procedure. There's absolutely no blood loss. Wound infection, whenever it happens in cardiac surgery, happens because of starts with the infection of bone. So that is not there. Pain is very less. So analgesia and analgesia requirement are very less. There is minimal reduction of the chest wall, and the chances of nerve injury are not there, because with normal retraction, the chances of nerve injury are there, which is related to the brachial plexus. Also, there is no hindrance of shoulder movement. All this translates into an early discharge, full functional recovery, lifting weights, sleeping to sides, wearing a binder. All these traditional precautions are not there, and these are not a perfect candidates. But this is a 72-year-old guy. The kind of movement he's performing and this is day 3 post surgery, are not possible for a week or more than week, about 2 weeks after open surgery. So these are all elderly patients, and the range of movement, shoulder movement, you see without any pain. This is all day 3 post surgery. This was a 35-year-old patient, and he had acute MI, and we did a MICS in him. For somebody like him, it's a great benefit. Again, a young patient, but this is the ideal candidate. If you see his chest wall, very, very thin, slim, he's an ideal patient, but it can be done in suboptimal also. So this, you will appreciate the kind of advantage you get from MCS. So various cuts, but once again, I have put another slide for the valve surgery. But these all left-sided incision are for bypass. For valves, the cut is different. For example, we are not going to talk about the valve surgery because of lack of time. But this is the cut for AVR, aortic valve replacement, and this is a 75-year-old gentleman. Somebody was talking about TAVR, but TAVR has his own life. But here we have implanted a valve in a 75-year-old with MICS 5 centimeter cut. So nothing can beat this. Other kind of surgery. So this is a female patient which required a ASD repair. We can see a cosmetic incision. The incision is totally hidden under the breast. So obviously it's a cosmetic incision apart from sparing of breastbone. These are the other kind of surgeries which can be done by MICS, other kind of cardiac surgeries. And so I perform these procedures in numerous international and domestic patients. Once again, I want to say that this is not a universally applicable procedure. It cannot be done in every patient. It cannot replace the traditional bypass, but yet in a deserving patient, it will yield an excellent result. Patients who have poor heart or lung function or obesity or other factors will never be candidate for this. But if somebody is young, fit, or young or old, doesn't matter, but with preserved heart and lung function, they will yield a tremendous benefit from this procedure. I'd conclude my lecture here and thank you for your patience or the lack of it, because I can see a lot of. Thank you so much, ladies and gentlemen.
Thank you very much, Dr. Vaibhav, for this nice talk. Only one question is allowed because of paucity of time. Any question from the audience?
Thank you so much.
Thank you so much, sir. I would like to call upon the chairpersons to felicitate the speaker, please. A little round of appreciation would help. And I would like to call upon stage Dr. B.D. Naryal sir to felicitate the chairpersons, please. Thank you, sir. We also have the results of the poster presentation. I would like to call on stage Dr. R.G. Nautyal, sir, to give away the prizes to the winners of the poster presentation. The first prize, that's a cash prize of rupees 3,500, goes to Dr. Sharad Bansal. Congratulations. The second prize, that's a cash prize of rupees 2,500, is being given to Dr. Akanksha Bankoti. Dr. Akanksha. There is a tag at the third position. We have two winners. The cash prize would be divided rupees 1,000 each to Dr. Mayank Negi and Dr. Anup Kohli. Congratulations to all winners. This prize distribution now will be followed by the inauguration ceremony and the launch of our souvenir. Thank you, sir. Once again, I would take the pleasure of introducing our IMA faculty, Dr. C. Joshi, sir, State President, IMA Uttarakhand. Sir. Dr. J. Surana, sir, Patron and past State President, IMA Uttarakhand. Dr. K.C. Sharma, sir, Chairman, CGP Uttarakhand. Dr. Arvind Sharma, sir, past State President, IMA Uttarakhand. Dr. J.S. Bhandari, sir, President, IMA Haldwani. Dr. D.C. Pant, sir, the Organizing Chairman, IMA Haldwani. Dr. Sanjay Singh, sir, the Secretary, IMA Haldwani. Dr. Prateep Pandey, sir, Organizing Secretary, IMA Haldwani. and Dr. R.K. Khurana ma'am, Senior Member IM. I would like to call upon stage Dr. D.C. Pant sir to start the inauguration ceremony, sir.
सुस्वागतम सारे आगंतुकों का respected senior, dear friends and colleagues, and my juniors. I feel extremely delighted and honored to welcome each one you are present here to participate in the landmark state CME, where we will not only discuss the scientific update on the various subjects, but also will try to find answer regarding our the increasing concern over legal issues. We will also discuss how to manage our hard-earned money to regarding high taxation and what can be our the investment strategy. I feel extended my warm welcome to all esteemed delegates and dignitaries, our highly knowledgeable speaker and learned chairperson with experience, vast experience from the different cities who have taken our extremely precious time to their valuable input, share their pulse of the knowledge with us. We are honored to have us state trained Dr. C.S. Joshi. Welcome, sir. Uh, our uh, our past president, Dr. G.S. Purana, and our patron, and Dr. Kailash Sharma, our patron of IB Haldwani. I am also welcome to the all dignitary and press and all the medical fraternity and pharma company to uh, to participate in this event. Thank you all and enjoy all the conferences and gala dinner at the night. Thank you, sir.
Now I would like to call upon stage Dr. C.S. Joshi sir to say a few words, please.
नमस्कार। यहाँ पर उपस्थित समस्त हमारे जो सीनियर्स हैं, डॉक्टर जी एस कुमार सर, इमीडिएट प्रेसिडेंट्स, फिलहाल डॉक्टर के शर्मा सर, चेयरमैन IMA CGP, डॉक्टर DC पंत, डॉक्टर JS भंडारी, डॉक्टर संजय सिंह, एंड डॉक्टर प्रदीप पांडे, तथा मेरे समस्त IMA परिवार के सदस्य गण तथा बाहर से आए यहाँ के डेलीगेट्स तथा स्पीकर्स, मैं आप सबको बधाई देता हूँ कि ये जो हमारा प्रयास है फॉर परफेक्शन either in knowledge, in wisdom or in other things, जो जर्नी थी हमने पोस्ट कोविड दोबारा शुरू करी है। इसी इस महीने अभी आज ये कॉन्फ्रेंस चल रही है IMA CGP की, बहुत अच्छा आयोजन है। मैं कि खास तौर से डॉक्टर प्रदीप पांडे वर्क वेरी हार्ड फॉर दिस, आई थिंक डॉक्टर DC पांडे, डॉक्टर प्रदीप पांडे, तो ये खास आज के हीरो यही हैं। बाकी सब जो मेरी टीम है, डॉक्टर DC पंत वगैरह है, दे आल्सो वेरी ये एक प्लेजेंट सरप्राइज है कि
इतनी अच्छी सीएमई लोग आ रहे हैं, पूरी भीड़ है। और अच्छी बात तो ये है कि जो विषय रखे हुए हैं बड़े वाइड विषय हैं। हम जैसे पुराने जो लोग हैं, जो हमसे पुराने डॉक्टर्स हैं, हम बैठे बात कर रहे थे कि जब हमने शुरू की थी मेडिकल प्रैक्टिस, तब और अब में कितना अंतर आ गया है। इट्स ऑलमोस्ट लाइक अ ड्रीम वर्ल्ड, सीइंग द रोबोट्स डूइंग सर्जरी, रैट्स, दोस थिंग्स। इसके अलावा जो और विषय भी हैं इसमें रखे गए हैं, मेडिकल फील्ड के हैं, सर्जरी के एडवांसेस हैं, कैंसर के एडवांसेस हैं, और लीगल एस्पेक्ट्स जो हैं, जो कि हमारी बहुत बड़ी प्रॉब्लम है आजकल की हमारी प्रोफेशन की। जो बिगेस्ट प्रॉब्लम आ रही है, जो कि हमको रोक रही है कि हम जो मरीज को हमारे बीच में चीज आ रही है, लॉ, इसका भी बीच में आना बहुत जरूरी है। तो इसको टू डिस्कस दोज थिंग्स वेरी इंपॉर्टेंट। तो उसके लिए मैं बधाई दूंगा ये जो आयोजक हैं कि इन्होंने ऐसे विषय रखे हैं आज जो कि समसामयिक विषय हैं, जिनका महत्व है। और एंड वी शुड टॉक मोर ऑफन सच थिंग्स। मुझसे कहा गया है डॉक्टर पंत द्वारा कि आप जो है इसी बहाने जो हमारी समस्याएं हैं, उसमें खासतौर से जो सीए की समस्या है, उस पर जो प्रोग्रेस हुई है, उस पर मैं कुछ बताऊं आप लोगों को। तो उस विषय में मैं आपको बताना चाहूँगा कि जब से हमारी नई टीम आई है, हमने कोशिश की कि जो दृष्टिकोण है अपना इस समस्या के समाधान के लिए, उसको बदला जाए। तो उस बदलाव के तरीके से हम लोगों ने कई स्टेप्स लिए हैं। हमने कोशिश की एक फंड जमा करने की, उसके अलावा फिर हमने कोशिश की कि थोड़ा सा हम स्टूडेंट हैं। तो हमारी मीटिंग हुई है विद द सीएम फ्यू वीक्स बैक। ही वाज वेरी पॉजिटिव। तो एंड देन ही आल्सो मेड हिज पीएस, ही वाज आल्सो वेरी पॉजिटिव। द थिंग व्हिच केम अप वाज दैट जो पीएस साहब थे, सेक्रेटरी साहब थे, ही एग्रीड टू इट कि देयर इज अ प्रॉब्लम इन द हिल्स, rather state which comprises 80% of hills. Number one, there's a problem with the bill. बिल परफेक्ट नहीं है। He agreed to this in principle कि सीए में कमियां हैं, उसमें दिक्कतें हैं। एंड नंबर थ्री, देयर इज अ प्रॉब्लम इन द इम्प्लीमेंटेशन ऑफ द सीए, उसमें दिक्कतें हैं। तो he said we cannot do it just one go. We have to go step by step. The first step जो है वो फीस माफ की शुरू हुई है। रैशनलाइजेशन में उन्होंने कहा कि अब जो दिक्कतें हैं सीए में वो आप हमें दिक्कत दीजिए, तब हम आगे बात करेंगे उस पर। वो दिक्कतें हमको दिक्कत दी हैं एंड वी आर वेटिंग फॉर अ नेक्स्ट मीटिंग टू हैपन। एंड he was very positive towards us, and it was the first meeting. My last 8 to 10 years I have been meeting them often, but this is the first time I felt very positive about this thing, that there is an officer who is trying to solve a problem, and I am very much confident that we will be able to achieve our goals in the near future. और प्लस आई एम ऑल्सो वेरी हैप्पी कि आजकल हमारे जो बाकी ब्रांचेस हैं, डिस्पाइट द डिफरेंसेस, सब हमारे साथ हैं। और they are also hoping for something to happen this time, and I am very much positive that by the end of my tenure in the month of December, I'll be able to achieve something worthwhile, and that is all I can wish and hope for. And I'm
शांत हो जाइए, थोड़ा सा बहुत इम्पोर्टेंट टॉपिक है सीए पे,
है ना,
कृपया शांत हो जाइए।
इसके अलावा जो है और प्रॉब्लम थी कि जो कि प्रॉब्लम थी फायर एजेंसी की प्रॉब्लम थी, या जो एसटीपी ईटीपी है। वी हैड अ मीटिंग विद द पॉल्यूशन बोर्ड आल्सो। The member secretary, Dr. Patnaik, Shri Patnaik, was very helpful to us. उन्होंने कहा कि हम मानते हैं कि आपके यहाँ छोटे अस्पताल हैं जिनमें ऐसे स्थान नहीं है कि वहाँ पर इस तरह से ईटीपी स्टिक लगाए जा सकें। आपकी प्रॉब्लम जेन्युइन है। अगर कोई रीजनल ऑफिसर आपको तंग करता है, यू जस्ट लेट मी नो। तो मेरे अस्पताल में चिट्ठी आई थी, तो आई सेंड द लेटर टू हिम, लेट्स सी व्हाट स्टेप्स ही टेक्स, बट ही इज आल्सो वेरी रिस्पॉन्सिव। ही आल्सो सेड कि आप लोग अपनी दिक्कतें में दिक्कत दीजिएगा, हम ये दिक्कतें सॉल्व करेंगे सेंट्रल गवर्नमेंट की तरफ से, कि पहाड़ में छोटी जगह हैं, इतने सेटअप लगाना संभव नहीं है। और तरह से तो इज आल्सो बिग प्रॉब्लम फॉर अस, एंड वी आर आल्सो ट्राइंग फॉर दैट। उसकी एक मीटिंग ड्यू है हमारे साथ दोनों के। अगेन वी होप फॉर समथिंग टू बी अचीव्ड इन दिस मैटर। तो बाकी और कोई ऐसा मुद्दा हो आप चाहें मुझसे हमसे कहना उठाना, तो मैं चाहूँगा कि जो है ब्रांचेस हमको बताएं इसके बारे में। बाकी आई एम देयर टू हेल्प यू, and I'm try my best to achieve, and my team is very much hopeful also. And again, I thank you again for coming to this conference today and having faith in me. Long live IMA. Jai Hind. Thank you.
Now I would like to invite Dr. J. Sanya sir to say a few words, please.
थैंक यू सो मच हमारे आज के प्रेसिडेंट आदरणीय डॉक्टर जोशी जी, ऑर्गेनाइजिंग चेयरमैन डॉक्टर टीसी पंत, हमारे डायनामिक सेक्रेटरी डॉक्टर मिस्टर पांडे, मैं हल्द्वानी, डॉक्टर संजय, डॉक्टर जे.एस. भंडारी जी, माय कलीग्स और डियर फ्रेंड्स, आज सीएम हो रही है, ये हिस्टोरिक हुई है। काफ़ी मेंबर्स यहाँ पर, काफ़ी रजिस्ट्रेशन हुआ है एंड थैंक्स टू ऑल द ऑर्गेनाइजिंग कमेटी जिन्होंने बहुत अच्छे लेक्चर्स रखे, और मैं धन्यवाद करना चाहता हूँ कि जितने भी यहाँ पर स्पीकर्स आए हैं और सारे कॉम्पिटेंट काफ़ी और न्यू टॉपिक्स लेके आए थे। देखिए, आज की डेट में जो हम हल्द्वानी में कर रहे हैं, अब हम सोच रहे हैं कि हल्द्वानी इसके आगे क्या बढ़ेगा, कैसे बढ़ेगा। तो अब जो उन्होंने बताया है, ये चीज़ें आपको हल्द्वानी में भी लानी है। तो जो रोबोटिक सर्जरीज़ हैं या जैसे आपके हार्ट में जो कर रहे हैं वेपराइज़ेशन वगैरह, लेज़र थेरेपी वगैरह, तो डेफिनिटली न्यू टेक्निक्स आर इन एंड वी हैव टू लुक आफ्टर दोज़ न्यू टेक्निक्स एंड वन शुड अंडरस्टैंड कि कमिंग टाइम पे हम लोग हाउ वी कैन गो फॉरवर्ड। और दूसरी बात ये है कि डॉक्टर जोशी ने काफ़ी बताया है कि सीए एक्ट 2010, हम लोग सारे आईएमए के मेंबर्स हैं, और इस समय जो आईएमए के जो मेंबर्स यहाँ पर इकट्ठे हुए हैं, ये जो इस कॉन्फ्रेंस में, ये एक अपेक्षा की जाती है कि इस ड्राइव को आगे ले जाएं। ये ड्राइव हमारी 2015 से चल रही है। हमको हर हालत में, जैसे सीए एक्ट में इन्होंने हमको जो हमारे रेट्स वगैरह वो कम किए हैं, पर हमारा जो टारगेट है, ये बहुत क्लियर है कि सीए 2010 यहाँ से एबॉलिश किया जाए और 50 बेड से कम ना लगे। तो ये हम लोगों की हम लोगों को प्रयत्न करना चाहिए। आईएमए इज़ वन, और आप सब आईएमए के मेंबर्स हैं। जो आईएमए के मेंबर्स नहीं बने हैं, तो मैं प्रार्थना करता हूँ कि आईएमए के मेंबर बने, और इसके साथ ही इस जो सीए 2010 के जो हम लोगों की लड़ाई एक तरीके से हमारी चल रही है, उसको आगे ले जाते हुए, और इसको जो है 2010 50 बेड से नीचे हटा दिया जाए। इसके साथ ही, क्योंकि अभी हमारे जो कमिंग टाइम पे इस साल डॉक्टर संध्या भटनागर बनेगी, तो अगले साल के लिए भी हमारे डायनेमिक, जैसे मैंने कहा डॉक्टर डीसी पांजी बहुत डायनेमिक हैं, तो प्रेसिडेंटशिप के लिए मैं रिक्वेस्ट करूँगा कि ये आगे के लिए भी ये बढ़ें आगे, क्योंकि देखिए जितने भी डायनेमिक यहाँ के रहे हैं, यहाँ रहे हैं, काशीपुर रहे या देहरादून रहे हैं या हरिद्वार रहे, रुड़की रहे, पर डेफिनेटली जो आगे आ रहे हैं इस समय, डॉक्टर डीसी पंत को आगे आना चाहिए, और उनको प्रेसिडेंटशिप के लिए सामने मैं पहले ही देता हूँ। थैंक यू सो मच। इसके साथ एक बार मैं फिर आप सबसे प्रार्थना करता हूँ कि आईएमए इज़ वन, डिफरेंस ऑफ ओपिनियन हो सकते हैं, बट डेफिनेटली आईएमए इज़ वन, और उसको साथ में, सबको साथ में लेते हुए आप सबने आगे बढ़ना है। थैंक यू सो मच।
Thank you so much, sir. Now we will be getting together for the launch of the much awaited IMX souvenir. Now, before I start the formal launch, I would like to call upon the stage Dr. Archana Singh ma'am and Dr. Tanuja Bora, because without their hard work and planning, this form would not have been possible. All the ideas, all the articles have been put into the present form because of the hard work of both these ladies. So please, Dr. Tanuja and ma'am, please be on the stage for the launch of the souvenir, which has been aptly titled. And I'll request the IMA faculty to please do the honors of launching the souvenir. So it has been aptly titled as Inspire, to inspire all of us. Thank you. Now I would like to call Dr. Pradeep Palle, sir, to say a few words, please.
Thank you, ma'am. Respected persons, please allow me to express my gratitude to the coordinating committee for all the hard work in planning this CME. I, on behalf of IMA Haldwani, thank all the speakers, chairpersons, delegates, and all the IMA members of Haldwani organizing team, exhibitors, all the associates who have helped in making this academic feast a success. I express my special thanks to the speakers who have come from Delhi and faced a lot of problems because of rain and waterlogged conditions of roads in Delhi. Especially Dr. P. N. Tiwari sir, who uh, who has stayed in the railway station last night because of this condition, but still he's managed to come here. Special thank to Dr. D.C. Pan sir for his continuous encouragement, Dr. Sanjay Singh, Dr. Archana ma'am, Dr. Tanuja, Dr. Manmeet, and Dr. Sadhya Sehana ma'am for conducting this CME very successfully. Thanks once again.
Thank you, everyone. Now we will be heading for the lunch session, and the sessions will resume at sharp 2:30 post the lunch. Thank you.
One minute, please. 1 minute, please. सारे थैंक्स के बीच में एक दो लोग ऐसे हैं जिनके बगैर ये सीएमई हो पाना मुश्किल था। मैं उनको आगे स्टेज से बुलाना चाहूँगा और डॉक्टर CS जोशी सर से रिक्वेस्ट करूँगा कि उनको एक देंगे। मिस्टर पंकज पंत और मिस्टर हरीश तिवारी, प्लीज। मिस्टर हरीश तिवारी, इन लोगों ने बहुत हेल्प की है दिन रात। थैंक यू। मैडम डॉक्टर श्रद्धा सहाना मैम प्लीज। डॉक्टर श्रद्धा सहाना मैम प्लीज। डॉक्टर मनमीत मैम। डॉक्टर अर्चना सिंह मैम। डॉक्टर अर्चना सिंह। डॉक्टर तनुजा बोरा। For all your hard work. Thank you. Thanks to all. Thank you, sir.
थोड़ा और बड़ा
और बड़ा
इससे बोलना।
ये हमारे आईएमए के स्किप और बात भी कर लो और दोनों वो से बात करूंगा कि वो से क्लियरिफिकेशन करा के तो अच्छा बात दे वो तो ये है मेंबर की तरह काम करो ठीक है।